A very good morning and warm welcome to everyone to the meeting this morning of the board of Powys Teaching Health Board. Bore da a chroeso I bob un y bore yma i'n cyfarfod ni fel Bwrdd Iechyd Powys. A chroeso arbennig wrth gwrs i'r rai ohonoch chi sydd yn gwylio y cyfarfod yn fyw ar-lein, ac hefyd i rai ohonoch chi fydd yn gwylio'r recordiad y cyfarfod fydd ar gael ar-lein ar ôl I ni orffen ein cyfarfod ni y bore yma. Not only a welcome to those in the meeting, but also to those online who are watching our meeting this morning, and indeed to those who will watch the recording of the meeting that will be available online after we finish today. So, very warm welcome. Carl Cooper ydw I, sef cadeirydd Bwrdd Iechyd Powys, ac wrth I ni symud trwy y cyfarfod y bore yma, fe welwch chi ar eich sgrin enwau yr aelodau o'r bwrdd fydd yn cyfrannu at trafodaethau. As we move through our meeting this morning, you will see on your screens information that tells you who the board members are, and also who can't be with us today and who have sent their apologies for absence. Ni, wrth gwrs, ydy Bwrdd Iechyd, ac fel bwrdd, dyn ni yn cynnwys aelodau gweithredol ac aelodau annibynnol. A gyda'n gilydd, dyn ni'n cydweithio mwyn sicrhau llywodraethiant effeithiol y Bwrdd Iechyd ym Mhawys. Yng ngwasanaeth, wrth gwrs, pobl Powys and cleiddion ni. We are the board of Powys Teaching Health Board. We comprise both executive and independent members, and we are tasked with the responsibility of governing the organisation in an effective and in a compliant and appropriate way. Our responsibility, in summary, is to set the strategic direction for the organisation, to set the risk appetite as we deliver against those strategic aims, and also to monitor delivery and performance, again, against those same strategic aims. Felly, dyna pam dyn ni yma, dyna ein cyfrifoldeb a'n pwrpas ni, ac dyna, wrth gwrs, beth fydd cynnwys ein busnes ni wrth I ni symud trwy y cyfarfod y bore yma. I just want to explain, before we get into the business of the meeting, if you see that that on occasions, people who contribute to the discussion don't look directly at the camera, but are looking to one side, then it's not because we've become distracted, it's because we're often working from multiple screens, and in my case, my board papers are on a screen to my right, and therefore occasionally I will need to look to the right just to make sure that we're on the right paper and in the right place in the meeting. So we will be taking a break at around about 11:15. So the meeting will just stop for 10 minutes or so whilst we take that break. And access to our agenda and to all the papers is available on our website, and therefore please go to our website and find those papers in order that you can follow our meeting in more detail. And so, with no further ado, we move to the agenda. Fe symudwn ni ymlaen at yr agenda y bore yma, ac y peth cyntaf dwi'n wneud ydy croesawu David Farnsworth, Joy Garfitt, our Interim Director of Operations isn't able to be with us today because she's not well and receiving medical treatment, but I'm really delighted that her interim Director of Operations, David Farnsworth, is with us. And David, good to have you with us, and we look forward to your contribution. I'm equally delighted to congratulate Nina Davis on her very recent appointment as the Substantive Director of Social Services and Wellbeing in Powys County Council. And Nina is an associate member of our board by virtue of that role. We've worked with Nina for many years, and we look forward to building on that very positive and constructive working relationship. But congratulations and a warm welcome to Nina. Are there any declarations of interest in relation to any item on the agenda? I should note that we do have some standing declarations of interest in connection with the closure of the branch surgery at Belmont. And Ronnie, Kate and Katie have declared their interest in previous meetings, and we will take those declarations as standing for this meeting. And what that will mean is that those colleagues won't participate in the discussion for that agenda item in their personal capacity. However, should Kate, in her capacity as Medical Director, or Katie, in her capacity as Regional Director of Llais, wish to provide a professional perspective, then that will certainly be appropriate and welcome. Are there any other declarations of interest? No, so we go then to our action log and to item 1.3. Helen, do you want to just take us through this? I can see that everything is a sea of green, and so completed. Are there any additional comments that you or anyone else would want to make in relation to the completed actions?
Diolch yn fawr, Carl, bore da pawb. Helen Bushell, Director of Corporate Governance and Board Secretary. So pleased to confirm that there are 7 completed actions on the action log. That's the sea of green, 2 in grey that have been transferred, 1 to the Delivery and Performance Committee, 1 to the Patient Experience, Quality and Safety Committee. Just for absolute clarity, to confirm 3 of the actions. The first one there is a deep dive into ambulance performance, and the Chair of Delivery and Performance will pick that up in his report a little bit later. And then 2 other items where we've said updates will come, 1 on food inspection and 1 on the Neville Hall MIU closure. Both of those will be picked up in Hayley's Chief Executive report shortly. Other than that, Carl, very happy to take any questions or comments. Thank you.
Thank you, Helen. Are there any comments, any contributions that anyone would like to make? So we go to Robert, please.
Thank you, Chair. Regarding item, Robert Lewis, independent member, regarding the commissioning and the WAST item there, 23081, yes, I think that Delivery and Performance is the vehicle for continuing to monitor ambulance performance. But I believe that a face-to-face meeting with the Commissioner and or WAST at some stage is desirable. I do not believe that such a meeting is urgent, but that it is important for 2 reasons. First, the response performance of WAST within our borders continues to be towards the bottom end of the performance table, and there seems to have been little improvement since our last meeting with them 2 years ago. But second, and looking to the longer term, the consequences of the various strategic changes that are being proposed elsewhere, for example, stroke services and the super hospital in Hywel Dda, which will affect, of course, Pronghraes as well, are that these might result in a further deterioration of service as well, so that WAST will have to alter the way they do things to prevent a further deterioration. So we will need some advanced planning, some pretty hefty fundamental changes but I'm content to leave the format, the timing, the vehicle, the precise representation of the board in any face-to-face meetings up to others. Thank you, Chair.
Hayley, our interim chief executive, I think wants to come in, so please do, Hayley.
Yeah, thank you. Robert, really important question, and I think that the work that we've already planned to schedule into the Delivery and Performance Committee is only one aspect of this. I know we will be in active conversations with both the Chief Ambulance Services Commissioner and Jason Killens, the Chief Executive of WAST, to come along to meet with us as a whole board through the board development planning sessions. The reason for that is absolutely right, Robert. It's not just the performance currently, the strategic changes are an important factor in our discussion, and also later on the agenda I can give you an update from the Emergency Ambulance Services Committee that took place yesterday regarding the next stage, phase 3 of the consultation regarding the EMIT service. So I think we're trying our best to try and get that in March for us. We're just at the moment in liaison around possible dates. So just to reassure Robert that those concerns that you've raised, it is important that we have that discussion with both WAST and the Chief Ambulance Services Commissioner, and we will have that in place in the next couple of months. Thanks.
You content, Robert?
Thank you, Chair.
Thank you. I can't see anyone coming in. I'm going to ask Ronnie. Ronnie, I just wondered if you wanted to give a comment or two in relation to the food hygiene issue that was referred to your committee, the committee that you chair, Delivery and Performance.
Thank you, Chair. I'm very happy so to do. I just wanted to say, first of all, how pleased I was to see that the food hygiene rating at Broncleast has gone back to 5 from 1, and that's a very steep ascent, which is quite unusual in my experience, and I want to reference that and to pay tribute to the team who have brought it about. But I'm also conscious that food hygiene ratings from the 9 kitchens are, and I think there are 9, Hayley, you'll correct me if I'm wrong, they're not routinely reported in at any stage to any part of the committee process. And that to me seems something that we might want to address. And I'd be very happy with the agreement of others to have those reports come to DNP. But there is another issue around all of this. And I know that staff in Broncleast and elsewhere have been working hard on the issue of food hygiene. I wonder if we might get some extra assurance into this mechanism in some way, because at the end of the day, the regulatory agencies award the food hygiene rating, but it is our responsibility to run that business hygienically and properly, whether that be in terms of the structure of the kitchens or the food handling. So I'm raising that really as an observation and a question, and asking if there's anything that we might do that would put a further level of assurance around all of this. Thank you.
Thank you, Ronnie. I can see that Hayley would like to comment, and also Claire Madsen, the responsible executive director for these issues. But we'll go firstly to Hayley. Thank you.
Thank you. So, Ronnie, just for awareness, really, that since the papers were circulated for this meeting, we've also had a rating recently on another hospital site, Ystrad, which has been allocated a rating of 5. But your point about our internal arrangements, and Claire will come in on this, I'm sure, is that we have done further quality assurance review of the systems and processes that we've got internally to strengthen those, and those have been in place by December recently. So I think we need to, your point about systematically reporting this work into a committee, we can include that in the work programme and make sure that that's coming in maybe twice a year to give you the further assurances, rather than awaiting those external sort of environmental health office reviews. But I'm sure Claire would want to give and offer some further assurance on the work that she's led Thank you.
Claire.
Thank you, Carl. Yeah, just to reiterate what Hayley was actually saying, we did put some extra measures in place to make sure that all of the learning that we had from the kitchen broncholists was implemented at every kitchen that we run, and we have an escalated level of scrutiny on all of the kitchens just in the interim period, and we've checked issues around training of staff and all of those other areas. As I say, we have had another inspection since, which was a 5 in Ostrogun Lice, which was very good. And also, we can look at how we report in that would be absolutely no problem to report that through DMP. So we'll activate that. I think the other thing to say is we've also been talking with internal audit as to whether we just arrange a cleaning kind of audit in about 6 to 8 months' time, just to make sure we're maintaining that standard. So I have been talking to internal audit as well, just for an extra scrutiny on ourselves.
Ronnie, are you content?
I am, Carl. I think it's just essential that we operate in a culture of no surprises.
Absolutely.
Thank you.
Lots of nodding heads. So yeah, thank you very much. I can't see that anyone else wants to contribute in connection with the action log, and so we move on to item 1.4 on our agenda, where we receive experience stories. I mentioned earlier that an important responsibility we have as a board is to monitor performance, and we do that in many ways, and some of the reports on our meeting today give us information and data and statistics, but a very important source of information is people's experience, patients' experience, the experience of staff who work with us in the organisation. And this is just one way. We have other ways, but this is just one way in which we seek to bring that information into our meetings and into our awareness, and use it to inform our decisions. So Claire Roche, our Director of Nursing and Midwifery, is going to introduce initially the patient experience. Thank you, Claire.
Diolch, thank you very much, Chair. Good morning, everybody. It gives me great pleasure this morning to be able to introduce Paul's story. And in this story, Paul tells the story of his own health, his diagnosis of cancer and the impact this has had on him. And he talks about his motivation for giving up smoking, what worked for him, and how the smoking cessation service supported him during the period of time when he was giving up smoking and what really mattered to him. Thank you.
Hi, my name is Mary-Ann and I'm one of the smoking cessation advisors in Powys. I'm here with Paul today, who's one of my clients and has successfully given up smoking. So Paul, tell us a little bit about how you found the service and what it's been like.
I found the service online, went onto Google, looked at stop smoking services. This came up. I then rang up, spoke to you. Within a week, I was then face to face with you. I had a carbon monoxide test, which very easy, just blowing into a tube. The results were absolutely horrific. The reason why I did it was I was diagnosed with stage 3 aggressive bladder cancer, which was a direct result of smoking. I've had my bladder, my prostate, my lymph nodes removed. I now have a stoma fitted, so I've got a bag that I have to, everything's directed to, they'll be there for the rest of my life, all due to smoking. And also the risk of secondary cancer after, if I still smoked, would be through the roof. So obviously, you know, it's a no-brainer.
Yeah.
I needed to stop. The service for me provided me with, there was an option of different things to help me give up, which I went for the nicotine patches and the inhalator. The inhalator wasn't for me, no. But I tried it, it just wasn't for me. The patches I find easy, you just peel off, pop them on, and it does stop the craving. The biggest issue is really, it's the mental side of trying to not think about it. But once that nicotine goes in, you don't really think that much about it. And it was just making sure that the nicotine patches were changed regularly. And for me, they were the best option. I also then had the option, if I needed to talk about it, I could ring up, have a chat about any issues or any problems I was having with it. I then have regular weekly meetings to see how I was progressing.
So how do you feel now that you've given up? Have you noticed any sort of health benefits, any changes to things?
Biggest ones for me, sense of smell and taste. Completely different to when I smoked. I mean, I don't suppose anybody realizes just how much it affects those. Breathing is better, a lot better than it was. Unfortunately, I've got blood clots in my lungs due to my treatment for my cancer, but that's the fact now you've got cancer due to smoking, which that's a hell of a thing to be told, though, to be fair. But again, it's that thing as well. I think it's with everybody. I think it's with anything like that is, oh, it never happened to me. I think that works with a lot of things. It's like, oh, it never happened to me. It'll be fine. I know people who smoke for 80 years and blah, blah, blah. Lucky them. It doesn't work like that for everybody. Until it happens to you, you don't realise just how, you know, just being cocky, oh, it'll never happen to me. Or, yeah, it's fine. It's good. It very well may not happen to you, but being told that it does, you know, you've got cancer, it's not a nice thing to be told. And then looking at the process of what they've got to do to hopefully get you to recover is even worse. And all down to some little white stick. That's what, 5 minutes of your life to smoke it. I mean, I'm 52. I don't want to be dead at 52 just from smoking. So for me, giving up smoking was the only choice. I had no other choice. I had to give up, and I couldn't do it on my own. I needed help to give up, which is why I looked online to find help to help me give up.
So Paul, do you think you could have quit before having this diagnosis?
Never in end to end, but to be honest, I was of this mindset of, oh, it won't happen to me. So I didn't even think about quitting.
So is there anything anybody could have said to you, Paul, before this to stop you from smoking?
For me, no. Too stubborn. Don't look at it logically. You don't look at the logical answers. They go, well, the reason they don't want me to do it is because they don't want me to die. You don't look at that. Oh, I didn't. And it was just like, no, it'll never happen to me anyway, so it's fine. And if it does happen to me, oh, well, I'll deal with it when it happens. Which, again, is all well and good to say that until you're told it, and it's a completely different story then. You know? It's always the words that nobody in their life would ever want to hear, like, you've got cancer. But the risk of it now is higher than it should be. It's 1 in 2 people now. And smoking has got a huge part to play in that.
So thank you for the story. Oh, Carl, I think it might be on you live. Apologies.
Yeah, carry on, Claire. We're back to you.
Diolch, thank you. So I want to thank Paul for obviously doing that film, and a huge thanks as well to Marianne for being an excellent interviewer. She clearly has a few more skills there, I'm sure, that she could adapt in terms of her interviewing capacity. But I think the story demonstrates obviously the value of our service to be able to help and support people to quit smoking. I think Paul very eloquently described how he needed that help to be able to support him. He didn't feel that he could do it on his own. And I think his openness about the impact of his diagnosis and how he talks so eloquently about the human nature of it will never happen to me is really impactful. The film is available on our website. It is used on our channels to be able to share Paul's story wider with the public and to be able to really share with people the value of our smoking cessation service and how it can help and support people. So thank you very much, Chair.
Thank you, Claire. So we go from our patient experience story to our staff experience story. Deborah Wood-Lawson, our Executive Director for Workforce and Organisation Development, is going to introduce this story. So thank you, Deb.
Carl and Borodar. I'm delighted to introduce Sue Williams, who will share her story with us today. Sue is the Health Disability Activity Practitioner for Powys Teaching Health Board, and she will be sharing her career journey, her return to practice, and her experience of joining our health board. Can I hand over to you now, please, Sue? Are you there, Sue?
I am. I was just waiting for the red line. Good morning, everybody, and thank you for letting me join you this morning. So my journey and story. I qualified as a physiotherapist in 1988 and then worked in various hospitals and roles in England until 1994, when I moved to Gwynedd in Wales. I worked in 2 local community hospitals and palliative care until 2001, and then became full-time mum to my 2 children. I intended to return to physiotherapy work once they were older, but due to our rural location, family members' illness and bereavement, and lack of childcare, I wasn't able to, and a suitable opportunity arose. So from 2010, I worked as an examinations invigilator for Aberystwyth University and managed a large holiday property. And in 2016, I'd actually started the process to become a school taxi driver, never imagining that I'd return to physiotherapy. When you've been out of practice for 5 years or more, you have to do 60 days of updating, which includes supervised practice, and I couldn't see how I could manage this. But a friend happened to call me about a Band 4 vacancy working with the community physiotherapist in my local area. I applied and was successful. So much had changed after 15 years out, in particular using computer systems for everything. I enjoyed the work and soon decided that I wanted to do my return to practice. With the support of my colleague Claire, I was able to re-register as a physiotherapist in 2017. I successfully applied for a Band 5 role and then progressed to Band 6 the following year, working with inpatients and community, and then COVID-19 red wards. However, during this time, Claire and another close physiotherapy colleague died of cancer, and I didn't feel that we were supported. Staff vacancies weren't able to be filled, and the stress of working during COVID-19 took its toll. I was on the verge of leaving the NHS. Then in early 2022, I saw a Powys Teaching Health Board job advert that would bring together my physiotherapy experience and my love of sport. So since May 2022, I've been the Health Disability Activity Practitioner for Powys Teaching Health Board. It was a brand new role following a successful pilot project in North Wales, and there's now a Health Disability Activity Practitioner in every health board in Wales. We work in partnership with Disability Sport Wales and the local authority sport development teams, and promote a signposting pathway to help disabled people become more active. Patients are signposted by their healthcare professional or social services team worker, which results in the patient being contacted by their local authority sports development team. They're given information about suitable local sport and physical activity opportunities. As part of my role, I've delivered sessions on physical activity and disability sport to university physiotherapy courses at Glyndŵr and Bangor universities alongside my Disability Sport Wales colleagues. Last autumn, the Health Disability Activity Partnership won the NHS Wales Award in the Improving Health and Wellbeing category. This process involved a virtual visit, and I was one of our 14 members who presented to the judges. Also in the autumn, myself and colleague Sam co-presented about the pathway at the Chartered Society of Physiotherapy conference in Cardiff. No other Powys Teaching Health Board teams were shortlisted for awards, nor teams or individuals presenting at conference. However, these events have given me the opportunity to both represent and fly the flag for Powys. So what do I like about working in Powys Teaching Health Board? It's been a breath of fresh air right from the start, an informative induction, the focus on staff wellbeing, including the 15 minutes wellbeing break, a very supportive manager, meaningful PADRs and welcoming teams, including the heads of therapy services. The training opportunities with the University of South Wales courses are excellent. What gets in the way? Well, the obvious, Powys is huge, so travel times are often long to meet with people face to face, but you become used to working on teams. NHS pressures aren't going away, particularly staff vacancies, and it can be difficult to arrange to meet with some frontline teams, but this is a national issue. Things to celebrate in Powys. I have excellent support from my manager, Aled Falvey, and I appreciate the contact I have with Vic Deakins as well. I feel that both are very approachable, in contrast to my previous role. Health board teams and individuals across Powys have been welcoming. In the summer, we had the NHS birthday celebrations, and I was delighted that the Health Board embraced Parkrun for the NHS in Bilthwells and Newtown. I was on the working group for these events, helping to promote the inclusive messages. I volunteered at the event in Newtown as tail walker. It was a great opportunity to collaborate with staff in the Health Board communications team and other organisations, and on the day I met and chatted with Hayley Thomas. Bearing in mind my past experience, I'm really pleased to see the Health Board considering training needs around bereavement. And on a national level, it's been fantastic for our team to win the NHS award, but our team lead, who was behind the pilot project, left us in July, and there's been a delay in the recruitment process starting. But the good news is that interviews are being held this week. So my message to the board, my headline is Positive Powys, due to the welcome and support I've received, the opportunities and how ideas have been responded to. My story is about my career journey and how fortunate I was to have an opportunity and the support to be able to return to NHS practice and now be enjoying this fantastic role in Powys. I wonder how many other healthcare professionals are in Powys who might return to practice with the right support. Thank you very much.
Thank you.
So no, back to you, Deb, please.
I was just going to say thank you so much, Sue. I know that kind of, the willingness of coming to the board is not everybody's cup of tea, and I'm really grateful that you have done that so eloquently. Your kind of passion and your determination and just the breadth of your experience. I think it's a privilege to have you as part of Powys Teaching Health Board, so I'm really grateful to you for sharing it. Back to you, Carl. Thank you.
Thank you.
Actually, on behalf of the board, Sue, absolutely echo that thanks, and that was very powerful and really significant, and so a big thank you. Our convention within board meetings is that we don't discuss the experiences shared with us, but we certainly do take that sharing of experience into, if you like, the body of information that we have that then influences our thinking and our decision making. So really important and much appreciated. Thank you. So we move on to item 1.5 on our agenda, and the updates initially from me as chair. My report is circulated, forms part of the papers for the board. The only additional comment I have is that there is a small section in my report about where we are in relation to the current recruitment process for a new substantive chief executive, and we meet today on the 31st of January, which happens to be officially the very last working day for Carol Schillerbeer as our substantive chief executive, who of course is on secondment to Betsy Cadwallader and begins her new role as the substantive chief executive in Betsy from tomorrow. And so it's absolutely appropriate, and I'm absolutely delighted just to take the opportunity to say a big thank you to Carol for all that she contributed and for all that she achieved during her 14-15 years in Powys and during her 8 years as chief executive. Before I came into this role, I had the privilege of working alongside Carol as a voluntary sector partner and saw firsthand how under her leadership the Health Board went from strength to strength, but also the wider healthcare and public service system improved because of her system-wide leadership. And the legacy that she leaves in relation to a very skilled executive team, an effective board, and as we've just heard from Sue, a culture within the organisation that supports and nurtures good practice. And so for all of that, and I'm sure much more, we want to say a big thank you to Carol and wish her very well in her new responsibilities. But that is my only additional comment. I'm happy to take the report as read, but if there are any questions or comments that anyone has on my report, then I'm happy to enter into conversation. I can't see anyone wanting to come in at this stage, in which case we move to the Vice Chair's report and to Kirsty. You're on mute, Kirsty. Oh, we're having difficulties. Oh, no, we still can't hear you.
Carl, I think Kirsty's showing us still on mute on my screen. Not sure if there's a...
No.
There you go, Kirsty, try that.
No. Kirsty, we clearly need to sort out some of your technical issues, so let's try to do that. But in the meantime, we'll go to the Chief Executive report and to Hayley. Thank you, Hayley.
Oh, thank you. Yes, so you introduced at the start David. Very grateful to David for stepping forward to cover the interim Director of Operations role today, so that's excellent. So you've covered that, and also you mentioned and congratulated Nina for the appointment substantively in her role, but also just generally in the council. It's really pleasing to see that the council now have a full executive team appointed to, and really looking forward to working in a stable environment on the joint priorities that we need to take forward for public services in Powys. Couple of areas we've covered already, but just wanted to highlight we have been notified fairly recently around the current status has remained the same. We continue to be in enhanced monitoring status as a health board, and that's based on the escalation and intervention arrangements that Welsh Government leads with Audit Wales and Health Inspectorate Wales twice a year to discuss any issues and information regarding all health boards across Wales. So again, that is in the domains of finances and planning, and our ability to deliver on a balanced financial position is a key requirement going forward for us as a health board. But our escalation status has remained stable in the last assessment. There's substantial work being undertaken around the National Joint Commissioning Joint Committee developments, and I might cover that a little bit later when we cover the partnership reports, if that's okay. But I just wanted to particularly highlight some changes in my report around the minor injury unit services in Gwent. And Bevan University Health Board have taken a decision to close the Neville Hall MIU between 1 in the morning and 7 in the morning, and we're still awaiting some of the details on the timetable for implementation regarding the decision that they've taken. Also some key developments around Shrewsbury and Telford NHS Trust, and really pleasing to see that the outline business case has been approved, really important milestone. I look forward to working with them for the next stage of development. And then just a final point to raise is around the position around EMIS and the Welsh Air Ambulance Service. That's contained in my Chief Exec report. Happy to take any questions on that now, or indeed cover it later when we cover the ESC update. But just for awareness that the phase 3 engagement process regarding the options to take forward that service was discussed yesterday in the Emergency Ambulance Services Committee and agreed in principle, subject to Llais finalising their view around the engagement papers, that we will start that phase 3 engagement at the end of this week. So developments there. So happy to take any questions on any of the points raised. I think that I didn't mention, and a bit of a prompt for myself, clearly in terms of winter pressures and the position currently that we've got across Wales in managing the first junior doctor industrial action in January as well has been substantially a challenge for a number of the providers across Wales, and a little bit later in an integrated performance report we'll cover a little bit more further those matters, but also probably helpful that maybe at either now or later in the IPR point that we pick up an update from Mez as Director of Public Health regarding some key public health issues and the latest position. I know there will be interest in the public, particularly around measles, that they may wish us to provide an update here in the meeting today. Thanks.
Thank you, Hayley. So we're going firstly to Robert.
Thank you, Chair. Hayley, my question is about the MIU changes at Neville Hall. Appreciate that the effect of this will be quite small, the volume will be quite small, but the MIU at Neville Hall is an enhanced service and it provides some things that our own MIUs can't. For example, my understanding is that you can take children between under 2, between 1 and 2 there, which might not be the case with some other of our services. So can we have a reassurance that when the time comes and when we have the details, that this will be communicated to the public? Because what we don't want is people going to the wrong place to discover that, you know, we can't get the service that they thought was available. Thank you.
Yeah, thank you, Robert. A really important point. And whenever any changes are put in place, it is incredibly important that the public understand what's on offer in different sites. So we'll work alongside Aneurin Bevan to make sure that that information is shared proactively with the public, and that is done prior to the go live date. So we'll be needing to check on the timescales for that, Robert, but we'll make sure that we work in partnership to particularly make sure that residents from the South Powys area that tend to head that way are fully receiving that information ahead of the change as well.
Thank you. And to Ronnie, please.
Thank you, Chair. Hayley, as always, a comprehensive and really helpful report. I know that Mez will pick up the issue of measles, but I'm just going to reference that again, if I may, and say that I'm actually quite concerned about this as an issue. What we have developing in the West Midlands is quite a serious hotspot. 75% of the cases are now located in that area, 20% in London and a small percentage elsewhere in England. But the West Midlands is only 70 miles or so from our border, and we do need to be very mindful of that. And I guess primarily for us, the issue is one of childhood vaccination. And, you know, as before, I'm just seeking assurance that we are across that and we're doing everything possible to increase our vaccination rates in order to achieve what is colloquially referred to as herd immunity. The other issue that I would just raise with you is, and this chimes with winter pressures, which you mentioned a moment ago, Amanda Pritchard, and I know that Amanda Pritchard, the writ of Amanda Pritchard doesn't run in Wales, but she recently spoke at the weekend about the 500 beds that the NHS had provided in England against the background of winter pressures. And I wondered, did we have a similar target in Wales generally? And if so, did we achieve it? And my third point, and this is quite a small one, you've referred to the fact that you're coming back to the National Commissioning Joint Committee developments. I noticed that there was reference, and I think it's something like the 5th bullet point, recruitment has commenced for the chair and lay members. I thought the use of the term lay members was quite interesting. I didn't know if that was intended to indicate that they were non-clinical or what exactly was meant by the term, because in my understanding, the term lay members within the NHS has a very specific meaning. So I'd be grateful for any clarification that there might be around that, and not necessarily at this meeting this morning. Thank you.
Thank you, Ronnie.
Shall I come back in? A number of points there, but I'll then hand over to Mez, if that's okay, Ronnie, to pick up the particular points at the start. But just in terms of the lay members, that is in active conversation at the moment, Ronnie, around the nomenclature that's being used. But the intention is that those members are people from all walks of life that could apply to become members of the new committee. But I will specifically confirm that once we finalise the governance sort of language around that. But so yeah, so that's been an issue of contention about what they're called in terms of the discussions that we've had in the committee implementation board. With regard to your issue around NHS England and the position around the beds issue, we have a similar situation in Wales, and we've had it year on year in winter where we increase additional capacity as and when needed in relating to surge requirements. So that is the case that every health board, including regional partnership boards, have been through their winter planning looking at how do they flex their capacity. To my knowledge, I don't think we've gathered that into the same sort of national statement as NHS England has at this stage. It was something I'd have to look into. Previous years we had the work around the 1,000 extra beds, if you recall, in previous years, but I don't think we've made a statement specifically on that in recent weeks. But happy to understand what the total picture is looking like, but certainly we've got that capacity at a local level to ensure that that is commissioned in line with requirements, and there will be I'm sure a comparative total that we could look at across Wales if we were to gather that information. If I was able to ask Mez as well to come in then on the earlier points, thanks.
Okay, diolch, Meryl Bowley, Director of Public Health, and thank you, Ronnie. I share your concerns as well regarding sort of measles and MMR uptake across the UK, particularly areas of cities in sort of England are reporting pockets of quite low uptake, and we need a coverage of 95% of MMR vaccine to try and prevent sort of outbreaks. So we've been doing some enhanced work over the last 6 months, which have included identifying young people aged up to 16 years who were under-vaccinated, and we've done a catch-up, and also enhanced work with primary care as well to do timely vaccination of our preschool children. That's been sort of effective in terms of increasing our uptake by age 4 to 94%. But we have also stood up a borders group now as well to look at what further action we can take. So our current uptake for young people up to the age of 16 for MMR1 is 94%, and then for MMR2 is 90.6 on average. So our work currently is drilling down now by each school in Powys to identify uptake there, and then we will do further targeted actions. It is a systems approach, and thankful to colleagues both in primary care, occupational health, and also the local authority in working together to look at what further action we can take to prevent sort of outbreaks in Powys. Hope that's helpful and happy to provide any further information.
No, that is helpful. As always, I'm just continuing to press for reassurance on this as the issue continues to build, because I suspect we're not done with it yet. Thank you.
Thank you very much, Ronnie. No one else wants to come in, so thank you, Hayley, for the report and for the discussion it stimulated. We're going to try, at least now, to go back to Kirsty, our Vice Chair, and any additional comments from you, Kirsty, on your report?
Apologies, everybody. Hopefully everybody can hear me now that I'm squatting in somebody's office. Grateful to Steve for that. There are no further comments on my report. We're happy to take any questions if people have any. Thank you.
Thanks, Kirsty. No one's indicating that they have a question or comment on Kirsty's report, so thank you, Kirsty, for that. In which case, we move on to item 1.6 on our agenda and to our various committee reports. And as I always explain, because I think it's very important, our committees play a very, very significant role in the governance of our organisation. It's in our committees that the detail, if you like, is scrutinised, and that we fulfil as a board a lot of the heavy lifting role in relation to scrutinising performance and so on. So the committees are a very important source of assurance, and therefore the committee chairs are a key people in providing that assurance. So we go initially back to Kirsty, who is going to provide an oral update after a recent meeting of our Patient Experience, Quality and Safety Committee. Thank you, Kirsty.
No, thank you, Carl. And as you said, the Patient Experience and Quality Committee met last week. Therefore, it's an oral report from us this time. There are three issues that I wanted to raise. The first two in relation to matters that the committee had previously brought to the attention of the board. The first is that around the capacity to fully implement and utilise the Civica system. The committee received a report on the current development of our use of Civica. We now have 35 questionnaires available to staff, so that rollout is increasing. Unfortunately, the committee heard that the numbers of patients that are responding via Civica to tell us about their experience is low at this point. However, the staff involved in the programme have been, analysing and looking at some of the barriers as to why that might be. We heard a very interesting case where patients who've received services outside of Powys have received a text message from Powys asking them about their experience. Many people have said, well, what's it got to do with you? I had my surgery somewhere else. So trying to explain to people why we're interested as a health board in their experience and services outside. Unfortunately, some people thought they were being scammed when they received that text message. But these are all learning experiences where we can reflect and communicate, because everybody in the organisation is very keen to use Civica effectively to capture patients' experience and satisfaction. The second matter that we've previously brought to board was around infection prevention and control, and the committee continues to monitor the improvement plan, and we were very pleased to note that the plan is making very good progress. All actions bar one are expected to be achieved and delivered within the time frames, and the outstanding action is hoped to be completed by Q4. So the committee was very pleased to note the implementation of the IP&C improvement plan. Finally, just to draw to people's attention, the committee received a paper on the outcomes of a recent incident management quality and safety review of mental health services. The committee took assurance that a plan will now be developed and approved by the executive committee to address the findings of that report. And the expectation of the committee is that we will return to this matter in our April meeting. That's the end of my oral report, but happy to take questions. Thank you.
Thank you very much, Kirsty. I'm just pausing for a second or two, just in case anybody does want to come in with a question or comment to Kirsty as Chair of Patient Experience, Quality and Safety. Doesn't seem that there is, so thank you, Kirsty. We move then to Hayley and to the Executive Committee report. Any additional comments, Hayley?
No, I'd take the paper as read because you can see it's quite a substantial number of matters that we've covered in executive team business, and happy to take any queries or questions. Thanks.
Thank you. Again, just a slight pause. Yes, Ian, please.
Thanks. Yes, Ian Phillips, independent member. Just a couple of questions, really. It's difficult when you've got such a lot to discuss. So there's two questions, really. One is a specific and one is more general. On the report within this, on the minutes of the 13th of December, you talk about the records management, and I know that goes to the audit committee, but it just seemed to me surprising to see good progress when the being reported when the original audit was in 2019. So that's just a comment and probably some work for the audit committee. And the bit is a more of a philosophical question that I guess we need to have a conversation outside of the board. I know we're undertaking our regular review of committee effectiveness, but in reading the report, I find it quite difficult because we're being asked to be assured. And I think with the volume and detail of things that are contained here, it's very difficult from the report itself to take assurance on the detail of what's been discussed. But we can, of course, take assurance that the issues were discussed, if you see what I mean. And that's a bit of a semantic point, but I think it's an important one, and one that I think that we need to reflect on as a board in terms of the content, the structure, the plain English. I think we can work to improve that. Thank you.
Thank you, Ian. I'll go to Hayley first of all for any comments in relation to the report, and then perhaps Helen Bushell might like to come in, our Director of Corporate Governance, in relation to the comment you make about the assurance. So firstly to Hayley.
Yeah, thank you, Ian. I mean, I know your comment around records management, and we can pick that up in another detailed meeting. But I think your point generally, and I know Helen will come in as well, is that I think that there's a large number of business that we discuss en route to committees and boards, a large number of papers that fall into there are separate reports regarding those coming through to committees and boards. But then there's a large amount of business which is about the day-to-day sort of operational running of the business, really. And I think that you know, we can have a discussion maybe in board development. Is there further assurances required around some of those matters? But I do feel there's a very clear sight between those matters that actually need to go through to committee and board, and a really strong process of peer consideration in executive committee en route to committee and board. So happy to discuss that further outside the meeting if helpful, Ian.
Helen.
Yeah, thanks, Ian, and thanks ever so much for the points raised. I think, you know, there are a few tricky bits in here, and there's a really high volume of material trying to be reported. And I think we try to communicate that as clearly as we can. Some of that's difficult, I'm sure, without a doubt. Some of that we can do much more clearly. So always happy to take any feedback on where we can improve doing some of those things. Just worth remembering that Executive Committee is a formal subcommittee of the board. It's got a slightly different role for the reasons that kind of Hayley just communicated, but I think think the assurance that is provided directly to the board, but also from executive committee to other committees, is an important factor. We need to be clear that that role is distinct, I think, and we're trying to improve the way that we reflect that. Your overall point about assurance, I see exactly what you're saying. I think the reality is that assurance across the committees accumulates over the year, and as you rightly say, when we get to committee effectiveness and the annual report from each committee, that's where you see it all in one place, albeit quite a long document. So I think when you're seeing things in isolation of each meeting, it's difficult to reflect on the whole term. So I accept that point, and we'll just consider how we reflect that in the annual report as we move forward. But thanks, Ian, and happy to take any further feedback as well.
Thank you. Ian, any?
Yeah, I just thought it was important in reading this to put ourselves in the position of an external person reading this, and I think that's the reflection. I think that's worthy of consideration. Thank you.
Thank you very much. So we move on now to the Audit Risk and Assurance Committee and to its chair, Robert Lewis, who has an oral report from, again, a meeting that happened very recently. Thank you, Robert.
Thank you. The information governance internal audit has been mentioned already, so I won't discuss that again. But some very good work by Ian Virgil from the internal audit team has allowed the work of Powys to be compared to other health boards within Wales. And this substantial piece of work shows that 67% of all the assurance ratings for Powys are reasonable or substantial, which is a relatively strong position. Clinical governance, albeit associated with a lower level of activity, appears slightly stronger for Powys. I'd just like to whet people's appetite that in March we have a particularly big agenda, which will include audit reports on IT infrastructure, estates, board and committee effectiveness, the All Wales review of planned care and also primary care. And the reason I mention this, Chair, is that as we approach March, I shall be making a formal application to you that each of the committee members be issued with 3 Weetabixes. Thank you.
Thank you very much, Robert. I'm sure Weetabixes can be provided, and there are other brands out there, aren't there? So, thank you for that. Are there any questions or comments to Robert in relation to the Audit Committee report? No, so thank you for that. We turn now to Ronnie, Chair of the Delivery and Performance Committee. We have a written report, but do you have any additional or comments to make, Ronnie?
Thank you, Chair. I will just extemporise around this a little and say this is a 6-page report, which I think actually indicates the volume of business that's going through that committee. We are appropriately focused on the financial challenge for obvious reasons, as we should be. There's already been some reference to emergency access discussion this morning. We took the decision that that would be reported to board as an escalated matter. For our next meeting, we'll be looking once again at agency costs and the effective control of those. So I think at that point I will pause, say the rest of the report is as tabled, but happy to take any questions and or observations. Thank you.
Thank you, Ronnie. Just you mentioned the escalated matter. Can I just be clear in terms of it being escalated to board? Is that for our awareness? Is there any action that is asked of us as a board, or is it simply to put on our radar screen, as it were?
Thank you, Chair. It is my understanding that this is for awareness and it is to be put on your radar, but I would say firmly on your radar. Thank you.
Thank you very much. Are there any comments or questions to Ronnie and to the DMP, to the Delivery and Performance Committee? Helen, please.
Yeah, thank you, Carl. Thank you, Ronnie. So just to confirm, the escalated matter to board from Delivery and Performance Committee relates back to the earlier conversation that we had and the update that Hayley gave, that we were looking to bring the Chief Ambulance Services Commissioner and the Chief Executive of WAST into a future board session for a wider conversation. So I think that's the action that will follow from it, as well as the ongoing monitoring and support from the committee as well.
Thank you. Just before we move on to the next committee report, I wonder if I might just ask generally, board members, as well, of course, as internal audit and our structured assessment processes, have all raised the issue that that we as a board should be more cited on primary care performance, and, if you like, the comment that we're not, and so you know, what does performance look like in terms of our GP provision and indeed other aspects of primary care, which is a different matter, I think, although a complementary matter to how are the clusters doing. And so I just wanted to get a sense of what can we expect to happen and how and when in relation to improving our performance citedness and our performance management of primary care. Now, I don't know. It may be that Hayley, you or other colleagues want to come in, but of course, D&P may have a particular role to play in that process. But is it to you, Hayley?
Yeah, I'm happy to come in first. Pete may want to add as well. So I think we recognise, obviously it's in our draft structured assessment report from the Wales Audit Office as well. So we are already undertaking work with the primary care team and the performance team to see to set out an offer really about what we can bring in terms of strengthening that visibility through to committee and to board regarding primary care performance generally, as you say, not just GPs, across all of the independent contractors, but also how we can bring a greater level of detail around the work that we're doing to implement the strategic programme for primary care and the cluster development work as well. So I would expect in terms of the exactly when, how and detail, I think maybe we could discuss that as a board to make sure that it does meet your requirements. There are some technical aspects around this, around availability of contractual information and where's best to have those discussions, but I'm confident that we can build it into our committee and board work programme for going into next year with that much clearer reporting lines through to the board, which will give us further assurance on the detail. But I just wanted to reassure you, we do still sort of in the executive space have substantial levels of detail that we are aware of, and as Director of Primary Care, Pete, I don't know if you want to give a little bit of insight. It's not that this work isn't taking place, it's a question of making sure that the site of it is going through in proportionate terms through to committee and boards. Thanks.
Pete.
Yeah, thanks, Hayley. I don't think there's a lot to add on what you've said. As you've informed the board, we're working with our performance colleagues to develop a dashboard which reports on those metrics as appropriate, so that the board can get assurance, so that we can take action on any areas of concern. As Hayley said, we have regular reports through our various committee structures in terms of access and primary care performance across all the different professions, and as again Hayley said, there's making sure we have the right information at the right time, linking in with our independent practitioners who are independent businesses, and getting that data in a position that gives the assurance that we're looking for. But that work is in train, and obviously we can check that it meets the requirements of the board as well. Thank you.
Thank you, Pete. So that's reassuring, but I'm quite keen to capture that as an action from our discussion today, and that, you know, as Hayley and Pete have helpfully said, you know, so that you know, the process does actually deliver the information that we need and that source of assurance that that we will find helpful. So thank you for that. We go now to Ian, Chair of our Workforce and Culture Committee. Again, any additional comments, Ian?
I'm going to take the short report as read. I did want to just draw some parallels really to the start of our board meeting today, which is we are trying to focus on strengthening our listening to the staff voice, which you'll see that we started our meeting. I wanted particularly to focus on the element of the Director of Workforce and OD's report, which really shows that we're trying also to focus on the long-term solutions, developing the workforce, the Aspiring Nurses programme, making Powys a great place to work, and opportunities for careers for people, how we strengthen that for people that live in Powys, to sort some of our ongoing wicked problems that were highlighted by Sue earlier on in terms of the difficulties in recruitment. So that's what we're trying to do in terms of the work of this committee that I wanted to pay particular attention to.
Thank you, Ian. I can't see anyone indicating that they want to ask a question or comment on this report. So again, big thank you to Ian and to members of that committee. Culture is sometimes perhaps seen as a more soft matter, but as we all know, it's absolutely fundamentally centrally crucial, and so a very important committee. Thank you. We turn now to charitable funds. I chair charitable funds. I don't have any additional comments to make on the report itself. However, a recent development has meant that we are probably going to be in a position of needing to submit our accounts later than the deadline, and therefore we will need to inform the Charity Commission of this fact. But I'll go to Pete, who will explain the situation. Thank you, Pete.
Yeah, thank you, Chair. So just at a high level, the Health Board's not going to be in a position to file its 22-23 charitable fund accounts with the Charity Commission by the deadline, which is today. Our final audit opinion from Audit Wales is pending third-party control assurance from our investment management company. The rest of the audit is complete with no issues. And the issue in relation to our investment management company is being worked through to resolve as soon as possible. So as soon as that's received and the audit is complete, we will then file our accounts with the Charity Commission. A very high level indication. Happy to take any questions. Thank you.
Thank you. Hayley, please.
Yeah, thank you. Not really a question, just a comment really, that I really appreciate that update, Pete, and also just for awareness, this is a matter that is affecting other health boards' ability to submit because of the additional audit work. I think the standards have slightly changed that's required for the auditors to undertake. So it's not a Powys only issue, it is an issue that is impacting upon a number of health boards.
Thank you, Hayley. And Ian?
I didn't want to comment specifically on this bit, but just on another part of your report. Do you want me to do that now, Carl?
Yeah, please do. Yeah.
I just a comment really. Really welcome the part of the report that talks about the pilot on the wet macular degeneration app, and just one word for the future consideration, because I suspect our hope and expectation is that that will be successful, and just thinking about how that might be rolled out. And just a word to Pete to make sure that we've covered the issues of patient identification in that, so that we can actually link those records into the overall electronic patient record, should that pilot be successful and we roll it out. So just a word of caution and from previous experience that we need to think about that integration of the information record. If we can pick that up, that would be really good, but a really exciting development.
Thank you. Do you have any comment, Pete?
Just so we're make sure that that's the case, Ian. But and then in terms of the pilot, if successful, it'll go through our normal process in terms of an area for rolling out. It will go through the investment benefits group, and as part of that, we make sure all that relevant assurance around, excuse me, everything talking to each other is in place, etc.
Great,
just a really good flag. Thanks, Ian.
Good to consider this now rather than later while we're at the design phase. So thank you very much.
Thank you. And finally, in terms of our committee reports, we go back to Robert, Chair of our Planning, Partnership and Population Health Committee. Any additional comments, Robert?
No, Chair. I reported verbally on this meeting last time, the 16th of November, so this is simply the minutes catching up. So no further observations from me. Thank you.
Thank you. And I can't see that anyone has a question or comment on this report, and so that concludes the committee reports. And a big thank you to all chairs, all members for the huge amount of work that is done by and through our committees. So appreciated. Just formally, the recommendation is that we receive these summary assurance reports and we receive them as assurance that board committees are fulfilling their roles and reporting accordingly to the board. If anyone doesn't support that recommendation, would you please indicate? So it's supported unanimously. We turn now to Dr. Kate Wright, our Medical Director, who's going to introduce item 2.1 on independent patient funding requests, a policy revision. Thank you, Kate.
Good morning, everybody. There's a paper and a few appendixes attached, which I will take as read, but I will take us through the most important parts of the report. So the purpose of the paper is to present the outcomes of an engagement process which has been undertaken through lots of stakeholders, through Wales, health boards, excuse me, WISC, medical directors and a wide range of other stakeholders to review the IPFR, the Independent Patient Funding Request Policy. So what is asked is that the board's asked to note the report and the methodology described within it in terms of engagement and process, to note the proposed changes which are outlined in the paper, and to approve the local adoption of the All Wales IPFR policy. So just by way of background, then the policy is owned by individual health boards jointly, and each health board has their own IPFR panel. So we are asked to agree to approve this policy, which will then be passed on, if all the health boards agree, to Welsh Government for ratification. The background to this is we've had an IPFR policy, and the IPFR process is a process whereby individual funding is considered for patients for treatments that would not normally be funded by health boards. The principle is to ensure that we have the correct balance between making sure we have individual patients' needs met, whilst also making sure that we're meeting the needs of the wider population. So there is a really quite strict and prescribed process which every health board has a process to follow. In 2021, there was a judicial review when an IPFR decision was overturned, and that has led to a review of the policy, which is the work that has been done since then. The details of the review are included in the papers, and I don't propose to go through all of those. But the changes, I think, to highlight, there are no significant substantial changes to the policy. The wording, some of the judicial review commented on the way the decisions had been made, had perhaps not fully interpreted the policy as its original purpose. So that has been reviewed. There has been some rewording, removal of jargon, and trying to improve the clarity of the wording of the report. A table has been introduced at the back of the policy, sorry, not report, policy. Table has been introduced at the back of the policy to bring out the important principles more clearly in terms of decision making. So there's been restructuring, and the wording has been looked at again with the KC to be sure that we're in the right position in terms of clarity and legal status. So I think those are the most important elements. I hope there's lots and lots of detail in the paper. I will stop there, but I'll happily take any questions.
Thank you very much, Kate. Kirsty would like to come in, so over to you, Kirsty.
Thank you very much, Kate. As you've just said at the end of your presentation, that we've taken legal advice that the policy is now in a position that should prevent further legal challenges. Obviously, the policy is one thing, but implementing the policy and adhering to it is different. So should we approve this today, could you outline what steps we'll take as an organisation with our IPFR panel to ensure that there is training, updating, so that we can operate correctly within the new policy?
Thank you, Kirsty. So really important question. And again, so I think it's important to note that it's a policy, and that the way it's applied is critical. So we have a panel which is multidisciplinary, made up of senior clinicians with lay people. There is a very clearly laid out process. This will not bring a major change in process. So what we will need is just engagement of the panel to make sure they have understood, and I will personally make sure that is done, to make sure the subtle changes are understood. And I think they are understood anyway, because this has been a sort of iterative process, so the panel will be aware of these discussions. And a lot of this is simply the way the policy is carefully thought through. Every decision is difficult, so there is a process around every decision, and I think what's really important is the method by which decisions are really carefully documented and decision-making processes are outlined, and we are very careful to do that. I think that's really important, because often in describing the process and in describing the process for each individual patient, there are no two cases the same, then that actually aids the decision making process. So I am assured, having taken part in the process and from the assurances and the feedback that we receive, that is done very carefully, and that is something that we will continue to reinforce.
Kirsty, you content?
Yes, that's absolutely fine for me. Thank you, Kate.
Thank you. So we go now to Katie Blackburn, the Regional Director for Llais in Powys. Katie.
Diolch, Carl. Kate, I appreciating this is an all Wales review, so I do recognise that. I'm not aware that there's been any input from Llais from the point of view of a patient perspective, and I'm just wondering whether whether you know of. Well, I'll pick it up, and maybe it's something we could pick up outside of this meeting, recognising it's an all Wales review. But I'm just wondering whether you know of any plans that to look at it from a patient perspective.
So, and forgive me, I'm just looking at the detail, because there's a huge amount of detail in the methodology there. I don't want to give you incorrect information. I'm almost sure that there's certainly been lay involvement. I think, though, rather than I need to go through the detail, which I can do outside. This went on for a good year or so in 22-23. I'm sure there was involvement and lay involvement, but I will clarify that, Katie.
Thank you very much. Thank you.
Thank you. I can't see that anyone else wants to come in. Therefore, we go to the recommendation Everyone has the recommendation in the papers, so can read it for themselves. I don't intend to read everything out, but essentially the recommendation asks us to note the content of the report, to note the changes in the revised policy, and importantly, to approve the local adoption of the All Wales IPFR policy, which once it's been approved by all health boards, then it'll be shared with Welsh Government prior to adoption. So please indicate if you don't support that recommendation. So that's approved unanimously. Thank you. 2.2 on our agenda, again, another policy revision. And we go this time to Claire Roche, Director of Nursing and Midwifery, in relation to the Putting Things Right policy. Thank you, Claire.
Diolch, thank you, Chair. So this policy is intended to ensure that staff are familiar with the principles for effectively managing concerns. The policy is informed by the guidance produced for the NHS in Wales to effectively manage concerns according to the requirements. In the National Health Service Concerns, Complaints and Redress Arrangements of Wales Regulations 2011. So our Powys policy has been updated as a result of Welsh Government Putting Things Right guidance being updated last year. And this was updated to ensure that the duty of candour is included as a result of the duty of quality and candour being in effect on all organisations from the 1st of April 2023. It's really important to note that the term concern incorporates complaints, claims and reported patient safety incidents, and includes concerns which trigger the candour procedure as set out in the Duty of Candour Procedure Regulations 2023. The national guidelines were updated because of the duty of candour being implemented last year, and our policy has been updated to reflect that and is therefore recommended to board for approval. Thank you, Chair.
Thank you. Kirsty, please. Kirsty, can you hear us, or are we still having difficulties connecting with you? It seems that we are. So again, whilst we try to help Kirsty with her technical problems, we go to Simon.
Yeah, I just had a query at around 3.4 in terms of whether and where we involve advocacy support for those who may lack capacity. I'm just thinking in terms of learning disability arena and whether reference to advocacy support should be made at this part of the policy.
Sincere apologies, Simon. I was having some difficulty accessing my papers there, so I can't actually look at section 3.4 at the moment. I do apologise, it's frozen on my screen, but certainly advocacy would be considered in that case.
Okay, thank you.
Okay, we'll try to go back to Kirsty.
I'm so sorry, everybody. My goodness me. I'm hoping you can hear me now. Claire, yep. It's to ask the same question really I asked Kate in the previous item, and that's about implementing the policy. And I'm particularly interested to understand about our capacity within Powys to have appropriately trained and qualified and confident investigators and people who are asked to undertake that role having the time to be able to do it, because clearly they're a really important part of the process. So just if you could give some assurance around our ability to implement this policy and making sure that all people who might be required to implement it know about it, and we're doing it in a consistent way. because obviously that is key as well. And then just to finally confirm, I'm sure it's there somewhere, that this policy will be available to staff and patients through the medium of Welsh, so that they can read this policy in a language of their choice.
Thank you, Kirsty. So in relation to being available in the medium of Welsh, yes, it will be. So that's an easy question to be able to answer. In terms of the training and the consistency of approach, so over the last 18 months actually, and in preparation for the duty of quality, the Central Quality and Safety team have been really focused on investigation training. We have had an excellent uptake of colleagues from across the Health Board undertaking investigation training, and we have been strengthening our infrastructure in terms of support across the whole of the organisation with the quality and safety team to those people throughout our organisation, whether those be frontline managers or people who have a quality and safety governance role, to adopt a consistent approach in application of the regulations. I think it's really important to remember that the regulations have actually been in effect since 2012, but this guidance was revised last year to be able to strengthen it, particularly in relation to the duty of candour, and clearly in terms of our preparation and our implementation of the duty of candour, wherever we've had the opportunity to have touch points in the organisation with investigation training, then we have ensured that we have included the requirements of the duty of candour. In relation to the capacity, I think, you know, in reality, capacity is always a challenge. It was a challenge before the duty of candour coming into effect on us as organisations, and our challenges in terms of capacity are no different to other organisations. However, what we are starting to see is with the really significant amount of people that we've had through our training and our support for them when they are undertaking investigations, we are starting to see that the quality of investigations is beginning to improve, and that for me is an indicator that people's confidence and competence is growing in relation to undertaking investigations. But clearly that is a road and a priority for us that we will continue to travel.
Okay, thank you. So we've got another couple of people wanting to come in, and then probably we need to move on in our agenda. But initially, please, to Cathy.
Hi, Kath Poynton, independent board member for trade unions. It's just a couple of comments, really, if I'm honest, Claire. I find that the language throughout the document keeps changing, so that could possibly be reviewed to keep it consistent, and that the document's quite a long document for staff or patients to read all the way through to get to the bits that they need. And also the question I want to ask, before it comes to exec, etc., is the policy or this type of policy put through a form of review group? As in Kate's just described, it goes to a multidisciplinary committee, etc., before it comes through.
Okay, Cathy, I'll seek to answer those questions. So in terms of the language reflects the Putting Things Right guidance, which is National Welsh Government guidance. And I do take your point that the language can be a little bit confusing for people. I recognise that I and my team and others across the organisation that work in this arena are extremely close to this. So when somebody mentions the word concerns to me, I already know that that is an umbrella term for patient safety incidents, complaints or claims. we do state that in the policy, whether or not it stands out quite enough as it should do. So I think it's a good challenge, and maybe we can highlight that a little bit more. But it nevertheless reflects the national, putting things right regulations. And I think that leads me into the answer of the second question around how long the policy is. If you take your time to read the Putting Things Right guidance and all of the regulations for putting things right, it is extremely long, is extremely complicated, and this policy has done its best to be able to distill that. But there is a limit as to how much we can distill that, where we start to lose the impact of the regulations. So I guess that is a little bit out of our control, given that the regulations are such a long piece of legislation. We have tried to make sense of what can be a very complicated agenda to navigate at times. We have tried to make that a little bit more simple by the flowcharts that are at the end of the policy. And I think what is really important in this arena is the infrastructure that we have across the organisation, whereby we can support, mentor and develop people's confidence and competence dealing with managing putting things right through the culture that we have with the quality and safety team, working with all of our colleagues across the organisation. There was another bit you said there then, and I'm sorry, I didn't write it down, the last question.
It was just sort of asking, does the policy, or has the policy gone through a review group and not just sort of a standalone desktop exercise?
Yes. So I think in relation to this policy, we need to remember that this was an update to the policy. So, the original policy that we would have had, which would have been done, a number of years ago, and I wasn't here then, but I don't want to make an assumption, but I would have expected that to have gone through that process. This is an update on the basis that the Putting Things Right guidance has been updated by Welsh Government only in relation to the duty of candour, and the duty of candour and the duty of quality are mandated on us as an organisation. So, it would probably be inappropriate to do a consultation on that across the organisation, because we are mandated in law to be able to do that. So for this updated policy, that hasn't been the case, but I would argue that neither has it been required.
Okay, I can't see that Kathy wants to come back, so I'm going to go to Ronnie. But just before I ask Ronnie, if I could make a comment myself, Claire, thank you for your explanation around terminological consistency, because that was something that occurred to me as well. I was also left with a question in relation to formal and informal concerns or complaints. There didn't seem to be anything in the policy that told me how that was determined, whether there were any objective criteria that were used to determine what was formal or informal, and indeed who makes that judgment. But I'll go to Ronnie and then I'll come back finally to you. Thank you. Ronnie.
Thank you, Carl. I too have concerns about terminology. Terminology which may be confusing to us and is therefore doubly confusing to patients. What's a complaint and what's a concern? Claire, I do accept your point about it being an updated policy, but from my perspective, what matters to me is what this means to patients. And I look at a lot of these policies in England, which are not standardised in the way that this one is for Wales, and there is considerable variation in them. But what I will say is that they are always stronger and better when there is patient involvement in the process. And here I have in mind particularly the feedback form. So if there hasn't been to date patient involvement in all of this, then I think that's an issue on which I would have a concern. And I hope that that is recognised. Thank you.
Claire.
Yeah, so I agree with you, Ronnie. Our patients, our families, our communities have to be front and centre to this. And you know, in relation to the terminology being confusing, you know, we sometimes, or actually we often hear that from people who use our services, which is why it is really, really very important that we have arrangements in place to be able to ensure that we can explain that to people when they raise a concern with us. You know, that's why we've got a direct access to our Putting Things Right team that can field questions, can signpost people, and they do a great deal of that work that is often very, very hidden. We are obviously, you know, led by the fact that this is Welsh Government Putting Things Right regulations. The terminology changed from informal concerns to early resolution a number of years ago, and even for myself, you know, I sometimes slip back into that terminology, and it is something that we need to be aware of. What I would say in terms of our engagement with the public, we are frequently and consistently seeking to be able to get that continuous feedback. So not seeking to just reach out on one occasion and seek to get their views. We very recently did a survey with anybody who had raised a concern with us in terms of what was their experience of raising that concern. You know, how did they feel they were treated? Were they treated with dignity and respect? Did they have the question they were asking to us answered comprehensively? Did it feel like for them in that process? And we will continue to do that. So perhaps that's not drawn out in the policy, because it is a policy about how we need to adhere to the regulations, but I can assure you that in terms of putting our patients, our families and our communities at the centre of this, that is without doubt our priority and will continue to be so.
And Claire, could you speak up on my point around what determines informal and formal?
So this is obviously all within the regulations. Anybody who raises a concern, if that is, or complaint, let's use the word complaint because concern is an umbrella term. If somebody raises a complaint at the coalface with any member of our team, and the team deal with that on the spot, and that used to be a language that was used previously as well, then that is determined to be a complaint that has been raised, that has been dealt with in an early manner and has not progressed to being a formal complaint. If somebody wishes to raise a formal complaint with us, then they do that. So addressing us, you know, writing a formal letter to us, or an email, or indeed even through a phone call that would come through to our Putting Things Right central team. They would state that they wish to raise that formally, and our team would advise them about or even ask them if they wish to do that. And then we have 30 working days in which we need to respond to that complaint formally, and that is reported on our performance on how we respond in 30 days regularly through our integrated quality report, Chair.
Thank you, Claire. And you're saying that is set out in procedure or policy separate to what we have in front of us today. I suppose
So,
go on.
So what supports us in that is the Putting Things Right guidance, legislative document from Welsh Government.
Okay.
I think the fact that I'm being asked quite a lot of questions is highlighting to me that we probably need to ensure that there is a few little amendments that need to be made to the policy that draw out this and provide clarity. And, you know, that's absolutely fine, Chair. That is the purpose of scrutiny and challenge.
Sure.
Recognising that both I and my team are so close to this that sometimes it's quite implicit for us. But I will take all of the questions and comments that we've received today, and I will seek to provide a little bit more clarity as requested.
Okay, thank you, Claire. And yes, I think you're right. I think you know, there's been a few questions and comments, and clearly people are struggling a little bit with the policy as set out. So, but nonetheless, we're asked to approve the revising putting things right policy. I suppose, Claire, can you give us a sense of, you know, so we're approving a policy that you're saying might be subject to some tweaking?
I think it will be very minor tweaking, to be honest, Chair. It will about being able to draw out a few key things that provide a little bit more clarity. You know, for example, it does clearly state in there that the term concerns relates to incidents, complaints and claims. And it may well be that we may need to add within the policy a link to the putting things right guidance and legislation if colleagues feel that would be, you know, helpful.
Yeah, I think that personally, I think that would be helpful. But Helen, do you want to make a comment?
Yeah, thanks, Carl. I'm just reflecting on the conversation and what decision it is that the board is making today. I wonder if we just make a slightly different recommendation following the conversation, and whether or not, after Claire and the team have made those changes, whether or not that then comes back to you as the chair of the board, just to reflect on that and determine if you think that that can then be approved on behalf of the board. I don't think it needs to come back to full board unless colleagues have a different view, but I think it could be deferred to you as the chair.
Thank you very much, Helen. So to reflect that, the recommendation is that we approve the revised putting things right policy, subject to minor amendments in the light of this conversation that will be ultimately agreed by me as chair. Would you please indicate if you don't support that recommendation? So that's supported. Thank you very much indeed, and thank you, Claire, and to colleagues, of course, for all the hard work. So we will take a break in a minute or two, but we will take the next two agenda items and then we'll take a break. So we go to Helen and to the Director of Corporate Governance report. Thank you, Helen.
Thank you, Carl. So just a short report from me today for the board, covering two items. The first, just confirming that the common seal of the Health Board has been applied on one occasion back in December. Your colleagues will note in the report that we have got a slightly different process to what our standing orders set out. The standing orders state that it should be witnessed by myself when you, Carl, and Hayley, as the Chief Executive, sign it. Because of modern day working practices, we do that electronically now. We've got some checks and balances. So just to point that out, but otherwise I'd ask the board to take assurance on that application. The other matter then has also been considered by the Audit and Risk Assurance Committee. This is the board declarations of interest register. It's included in the papers. It's also available on the website. This has been updated to the end of December. So just to confirm that David, as our interim executive director of operations, community and mental health, has completed his form, and that will now be added to the register as per our process. So that's all publicly available, and I'd ask the board to receive that register and take assurance that the Audit and Risk Assurance Committee have also taken its own assurance on the process of that. Thank you, Carl.
Thank you. So I can't see that anyone wants to comment on these papers, so we'll go straight to the recommendation that we ratify the application of the common seal and that the action was taken in accordance with our standing orders, and that we also receive the contents of the register of interests for board members as of the 31st of December 23, and that the Audit and Corporate Governance Committee has also taken assurance as to the appropriateness of that process and that register and so on. So again, please indicate if you want to dissent or you don't support those recommendations. They too are supported unanimously, which means that we go to the minutes of our last meeting held on the 29th of November for accuracy and approval. Are there any amendments or corrections that anyone would like to suggest? No, so I propose that we accept those minutes as a correct record please indicate if you're if you think otherwise. So that those minutes are accepted. Well, thank you very much. We're running a little behind time. It's now nearly 20 past 11. I'm going to suggest, if I may, that we take, well, just over 10 minutes break, and that we reconvene at 11:30 for the rest of our agenda. So thank you very much. See you in 10 minutes or so. Wel, croeso nôl i'r cyfarfod. Dwi'n meddwl bod pob aelod, pob cydweithiwr wedi dychwelyd ar ôl yr egwyl. I think we're all back after our break, and so we'll reconvene our meeting and we go to our Director of Finance, Information and IT, Pete, for the Financial Performance Report Month 9. Thank you, Pete.
Yeah, thank you, Carl. So the finance report is included in the papers in the usual format. I will assume that everyone's had a chance to read the papers and just give a high-level overview of the key issues. As I move through the report, I'll reference the individual page number as included in that report. So picking up on page 1, as at month 9, the Health Board is continuing to hold its forecast to hit its targeted control total of 12 million. But as at month 9, we are adverse against the position to the tune of £589,000. So given that variance against our plan to hit the 12 million, we're still holding our forecast because that's within the range of what we can manage against our risks and opportunities as we go forward. The key areas to highlight, and these are themes that have been highlighted in every board meeting and are discussed in detail in our Delivery and Performance Committee, include our continued high level spend on agency, pressure against our commission services position. In the main, that relates to increased emergency activity, and in relation to our continuing healthcare and complex care packages. As Ronnie alluded to earlier, agency is subject to a further deep dive review, which is going to the next Delivery and Performance Committee. And as a reminder to everyone, it is essential that we keep a focus on these areas and minimise spend where possible. As I move through the report, it includes the usual analysis against those high spend areas. So you've got the charts of our income and our spend in relation to agency. So in November, we saw a significant spike in our agency spend, but that has reduced in December and brought down to previous months' levels, but still needs further improvement to help to meet our financial target. Our commissioning and contracting positions also included, as I've mentioned, emergency admissions are a significant challenge and pressure within the position, and the usual analysis in relation to our prescribing and our continuing healthcare forecast is also included. If I just reference onto page 7 details our performance against our savings target. As a reminder, in our original deficit plan, we included £7.5 million worth of savings target mitigating actions. As you will see from the page 7 of the report, that we're actually overperforming against that original target. Some of that overperformance relates to the need to identify further schemes to offset pressures in year, and an element relates to the additional ask in terms of being set the targeted control total of 12 million. There's detail there by exec lead, and there is a reference to the number of schemes which each area is developing. All of that detail is obviously held outside of the report as included here. Important point to note is that although we're exceeding our target, an element of that is non-recurrent. So if it's non-recurrent delivery, it means that will continue to be an ask as we go into next year. And this programme of the pipeline of developing ideas around savings is an ongoing basis, and we know that will be essential for delivering our plan going into next year. Also included in the report is some of the key risks and opportunities areas. And in summary, what I would say is that we continue to hold our... Sorry, before I give the summary, I would just reference to the last page of the finance report, Appendix 5, which gives that one-page summary of how our financial plan has moved from our original plan, the allocation of the additional funding we received in year, and the actions we've identified to hit our 12 million targeted control total. So in summary, we're holding our forecast to hit that control total. In doing that, it is essential that everyone takes the actions as identified within our plan. That's against our savings and mitigating actions, against the further actions we identified and approved as a board to deliver the additional 3.2 million improvement as set by Welsh Government, and for all budget holders to take action to minimise spend where possible. We are slightly off target against that plan to the tune of the circa 500,000, and we need to ensure that we achieve the opportunities and continue to manage the risk to deliver that position. What I haven't done is spent a lot of time on the capital position, but the capital position is all online and expected to be delivered within our capital resource limit, so nothing to escalate to the board. So I think I will pause there, Chair, and happy to take any comments, queries, or any further discussion in relation to the financial position. Thank you.
Thank you, Pete. Really effective and helpful summary, and as always, a very accessible and informative report. I just inviting colleagues to come in if you'd like to with any questions or comments on the financial report. Hayley, please. Oh, sorry. Yeah. Do you want to come in now, Hayley, or?
Yeah, no, yeah, if that's fine. Really helpful again report, Pete. But I mean, the seriousness of the financial situation that we're facing as a health board, both in relation to, as you describe, slightly wrong direction around the overspend and the position of hitting our target control by year end continues to be where we're heading and what we want to achieve, but we will have to take some additional actions as a result of this latest month 9 position. And a couple of areas I wanted to particularly reflect on. So I know that people are working really hard and are doing their best, so that's the first thing to say, but I think that there are some, how this talks to the next item a bit later about our plans for the future. There is a need for us to look at the current models that we've got going into our plans over the next 3 years in order to address some of the particular issues that we're facing. So a couple of highlights, you know, the increase in emergency presentations, the impact on planned care, and notwithstanding at the moment, understanding the impact of industrial action across the system is something that we'll be working alongside our partners, commissioned partners, to understand. But also there are a couple of particular growth areas. Mental health in the report was identified around variable pay, and also, and I know Nina's on the call, not you know, you may wish to comment, Nina, but the importance of us working across the system on some of these matters, particularly with the cost of delay around flow, is extremely substantial at the moment. So I guess my contribution to this conversation is we are where we are with the month 9 report, but it leads us to a place where, as a health board, we need to look at what is realistic and deliverable and sustainable in the long term, with that lens of the financial challenge, as well as maintaining quality and safety of services. And I think that as we move into the discussion points in a couple of items later, you know, we will have to take some additional actions of the last 2 months of the year in order to recover some of this. So, yeah. It's more a comment, really, Carl, than expecting Pete to respond.
No, actually, really important comment, Hayley, and I know Kirsty wants to come in as well. It was a very similar thing that was in my mind, that you know, we know that Welsh Government has injected substantial additional funding into the NHS in Wales in recent weeks, and that has been very helpful, very gratefully received. But it and you know, it's really good, Pete, that in the financial report we are on track for you know, for meeting that control target, notwithstanding the comments that Hayley's just made about the additional challenges that still poses. But I suppose I just wanted as well to echo that the general context still provides us with some real dilemmas, as not only as we end this year, but as we go into next year and into the future. So it's definite, we're not out of the woods by any way, shape or form. However, final comment from me, we are very much in that space of, and we will come on to this later, planning for a sustainable future that also addresses our duties in relation to safety and quality and so on, as Hayley quite rightly says. So absolutely. So thank you. We'll go to Kirsty, please.
Thank you, Chair Hayley, and to Pete. And I think it is worth stating again, isn't it, about, you know, despite the tremendous efforts of everybody involved, this still remains a really, really challenging situation. And the outlook is not one that seems to alleviate that pressure at any time soon on the front of finances. And I think you know, we all just need to keep that, you know, be reminded of that. I note, Pete, you know, the ongoing efforts around our variable pay, the spike you reported that has now come back down. And I know that this is, you know, a source of huge amounts of effort and, you know, interrogation by workforce colleagues. You know, everybody's looking very, very hard at that issue. And I'm just wondering whether at some stage we get to a point that says, actually, you know, to run the services that we're running and to maintain the quality of the services that we're running, actually, there is, you know, we're going to have to accept that our pay bill is going to be higher than perhaps we would want it to be. So what I'm trying to get to is, you know, despite all these efforts, we're still continuing to have some of these issues. At what point do we recognise that actually what we're trying to achieve is not possible? And what does that mean? And then on the issue of flow and the costs associated with delays in the entirety of the health and social care system, I'm wondering again if you know, whether, you know, ongoing discussions with our partners, and I know that Nina is on the call, ongoing discussions with our partners in the local authority are giving us a route map where we could see those cost pressures being reduced, if not in the short term, but in the medium and longer term.
Thank you, Kirsty. Pete, being that I think Kirsty has teed up Nina very, very nicely there. So let's go to Nina, and then we will come back to you, Pete, for a response. And then probably we'll need to move on to the next agenda item. But Nina, welcome. Thank you. Over to you.
Thank you, Chair. Thank you. And thank you, Pete, for the detailed report on the financial update. I mean, it's very clear that, you know, the finances are very challenging, not just for yourselves, but across, you know, local government as well, etc. So we really have those shared financial challenges, etc., with, you know, perhaps future potential challenging years to come as well, and I think we're all very aware of that. So I just wanted to kind of pick up on Hayley's points and just reiterate that it's really important that we work together with partners and as partners across the health and care sector. So that's, you know, health board, that's local authority, that's third sector, that's, you know, providers, etc. It's really important. We're not going to solve all the problems and the challenges are in isolation, and that partnership working is going to be absolutely key. And of course, a regional partnership board as well, real key space for all of us moving forward as well. And in terms, Kirsty, you were asking about the discharges, etc. Just to give you that assurance that we're prioritising that here in the local authority, working very closely with colleagues in the health board to do what we can. It is very difficult at the moment. It's very challenging. We are, as you'll be aware, in Powys, in the council, we've got a sustainable Powys. We're looking at place-based planning and very much working with Pavo and yourselves in the health board as well, looking at future plans. And it's really important that we do that together and work with you with your accelerated sustainable model as well. So yeah, and there's really good pieces of work happening in certain areas of joint working between ourselves, but we just need to really make sure we progress that at a pace now and expand that work wherever possible. So I just wanted to give my assurance to the board that, you know, in the local authority, we're absolutely committed to that and see that as really key moving forward. Thank you, Chair.
Thank you, Nina. So we go to Pete, and then we do have a couple of other people that want to come in. So I will make a little bit of extra time for that. Pete or Kate, is your comment to anything that's been a response to anything that's been said? So would it be helpful if we came to you before Pete, perhaps? Okay, thank you.
Yeah, thank you. Really important discussion. I just wanted, and I've said this before, but make no apologies for saying it again, that you know, the money's really important, but through every discussion we have, then the quality is what matters. And every discussion, every decision we've taken has been around outcomes and quality. And we know that the two are linked. We know that when we deliver a quality service, and often there's usually value in there as well. So that plays into our decision making, but also, you know, when we're looking, we've talked about the staffing and the difficulty with staffing and the agency cost, but a consideration there is, you know, the risks of agency working, which we know are generally not as safe as having substantive staff. So we're really working very hard to understand what, you know, the safest and most sustainable staffing model is, and the most safe and sustainable way of looking after our patients. That flow comes into that patient flow. That some of this is about capacity, and the more we can do to improve the flow in our system, which you've heard from Nina, we're working very, very hard on. Improve the safety of the system, the safety of our patients, and will deliver on money, and will also give us better outcomes for our patients. So that's a really key area of work. But I just really wanted to highlight that there are quality issues here as well as financial issues, which we are really, really cognizant of and looking at very closely.
Thank you, Kate. A really important and salient point. So I want to give Pete the very last word, as it were, on this item response. So let me go to David Farnsworth first, who again, interim director of operations, and a comment around operational response to variable pay and flow. We've got a final contribution from Simon, and then we'll go back to Pete. Thank you, David.
Diolch, Carl. Good morning. David Farnsworth, the Interim Director of Operations. I guess, Kirsty, I wanted to just link back your comments around whether obviously we need to accept some of these issues in relation to these pay issues. And as colleagues have said, we know that the reliance on agency staff is less than optimal, and actually developing a staffing model, and back to Hayley's point of how we create sustainable services, will have to be a conversation that we take moving forwards. And I think that's a really key issue of Hayley's there about how do we make our services more sustainable. There are conversations around bringing services closer, working together, both geographically and across fields, whether that's mental health and physical health, in a way that will help sustain our services, and that will be a model of care that we need to continue to develop. And then just looking at that flow conversation, similarly, it's about how we make our sustainable services sustainable. And as colleagues would understand, we have patients who are stranded in community hospitals for long periods of time, looking for other services elsewhere in the community, and how we maintain their health and welfare in a way that means that they need lower levels of care in the community, how we support them to avoid coming into our services in the first place, will be key. And of course, the accelerated sustainability model is where we are going to try and develop all of that. And from my perspective, operationally, that will be far more preferable than trying to deliver these very fragile services in a way that currently is not optimal for our patients.
Thank you, David. So Simon, Kirsty, then absolutely finally back to Pete. Simon.
Thank you, Chair. I wanted to just comment on how encouraged I was to hear Nina's comments and the commitment from the council to that close working, because that is so evidently critical to both quality care for our patients, but also to the financial position of the board. Also, really pleased to hear from you, Kate, around the priority attached to quality and patient care in all of the decision making. These are both really encouraging. My specific question on the finances was just to ask for a bit of clarification on the application for strategic cash support. What does that mean for us, and when are we likely to hear back from Welsh Government? Do we know? So that's my specific question. Thank you, Chair.
So Kirsty, please.
Yeah, I just wanted to thank both Kate and David for clarifying what I was trying to say, but not doing it very well. You know, around it is about, there's a difference, isn't there, between agency costs because somebody is off sick or we're filling in for somebody to go on a training course, as opposed to using agency to sustain a service or to deliver a quality service to whom patient security is so high that we just have to have extra staff in to make sure that the service and the quality is right. And I think there's two different issues, and it would be useful to try and unpick, you know, and pick the two so that we can get to exactly what Kate and David just described as a safe model of care with appropriate staffing levels, which then goes into our bottom line. And so thank you. And I feel, you know, I feel very assured, having heard from Kate and David, about the nature of that work. Thank you.
Thank you. So final response from you, Pete.
Thank you, Carl. Just to agree with Collie's comments, everyone. So for me, we know that we have limited resource. So when I say resource, I don't just mean money, I mean people, all of our resource. We need to make sure that we allocate that resource in the best possible way, put it in the right place to deliver those best outcomes, that safe and quality care that Kate alluded to. And Kirsty's point about, you know, we can't just keep saying the same thing around our agency spend is an issue, so we have to look at it differently. Can we re-provide those services in a different way? Can we make better use of the substantive resource and arrange ourselves in a way that uses that in the best way for the best outcomes? Again, it links into some of Nina's comments around the whole system. Collectively, we're all facing resource challenges, again, money and people and capacity. Between us, we need to identify the best part of the pathway and the best part of the system to put that resource to get the best outcomes. It's very easy comments I'm making, but that is the basis by which we should work through and do things, and it's the challenge that we face. And then the final part in Simon's question, so the strategic cash support. So in very simple terms, we're in a deficit position, so we will spend more than the money we receive. We need strategic cash support to give us that money to be able to discharge and make our payments to our creditors, etc. That has been part of a process that we've submitted our requirement, and that has been approved and confirmed by Welsh Government. So it's not an issue of concern for the board. And that's it from me, Carl. Thank you.
Thank you, Pete, and to all contributors. So we'll move to the recommendation that we receive the financial report, and we are assured that PTHB has effective financial monitoring and reporting mechanisms in place to enable us to consider and discuss the financial situation and forecast. So again, please indicate if you don't support that recommendation, in which case it's supported unanimously. We go from finance to operational performance and to our Director of Planning, Performance and Commissioning, Steve. Thanks, Steve.
Thank you, Chair, and morning, everyone. So this is the performance position to month 8, the end of November. The template of the report is similar in style to that which our colleagues have seen before. So I'll take the report as read, but I do want to draw out a number of key issues from both the covering paper and the detailed performance pack itself. So pages 2 and 3 of the cover paper do report our some of our ongoing challenges in our own provider arm around the delivery of our planned care. But we are still making progress despite some of those challenges on our long waiting reduction of patients. And also we've made some key appointments into planned care role and endoscopy in that recent period. Our own MIU services continue to report that good compliance level against the 4-hour target. But on the commission side, so where we commission services outside of Paris, it's an ongoing theme in terms of performance below target, particularly for, as we've heard this morning, around A&E, but also against cancer targets and referral to treatment times. Whilst we've discussed in some detail ambulance response times and so on, the Welsh Ambulance Service and health boards have agreed a winter impact plan, but despite those extra efforts going into the service to improve performance is quite poor still from an ambulance perspective. Today, in terms of winter pressures and system resilience, what we're seeing across Wales is virtually all district general hospitals at a high level of escalation due to winter pressures and emergency demand. South and the Shropshire system declared a critical incident yesterday, and they are still in that incident classification. And Wye Valley over in Hereford are also busy from an urgent care perspective. Page 4 and 5 of the report describes how we are performing against some of our own internal indicators and draws out a number of services that we feel merit escalation for further scrutiny, and all those services we have now got remedial action plans against, and we're seeking to identify at what point we return performance to compliance, and some of that narrative is included in the paper. Page 6 goes on to describe our performance against the ministerial measures. Now, at the present time, we're passing 3 out of the 9 targets, but when compared the November performance to the October performance, 5 out of those 6 indicators that we are failing did report improved performance during the month. The final chart on page 6 reports the mental health performance, and we are passing 6 out of 9 of those, and the 3 that we are not reporting before compliance against the target, we have got remedial action plans in place to try and improve performance, and the team met with a number of mental health colleagues yesterday, and I'll be able to give an update at a future meeting on progression on those areas. Long waiters across all of our commission providers is still an issue. So whilst we're improving our performance as a provider within Powys, we're seeing relatively slow progress both across England and Wales. In part, some of the capacity disruption has been caused by the juniors doctor strikes and consultant strikes that Hayley referred to a little earlier. But despite some of those challenges, as a provider, we are still making positive progress to try and improve sort of care close to home and additional services in Paris. So I just wanted to sort of update you on the board and the wider public on some improvements and developments we have made. So, for example, Robert Jones and Agnes Hunt, they will be providing additional orthopaedic services into North Paris during the remainder of this quarter, this financial year, where we'll be doing some surgical outpatient procedures for carpal tunnel and so on in that area. We've just agreed from April with Hywel Dda that we'll have colorectal outpatient clinics delivered in Paris, so that will avoid patients having to travel over to Bron-Gleis for that first outpatient appointment. So that's a trial that starts for 3 months from April. And similarly, we're under the discussions with Hywel Dda about developing rheumatology and neurology services into Paris. So whilst there are certain performance challenges in areas where we can influence capacity and improve outcomes for patients, we are still doing that. I will pause there, Chair, for any questions that I may need to bring colleagues in to respond on some of the detailed questioning with the performance pack. Thank you.
Absolutely fine, and thank you, Steve. We do have a couple of people wanting initially to contribute. So first, Robert.
Thank you, Chair. Steve, thank you once again and your team for this very detailed snapshot of performance. But I wanted you to put away the microscope. I know you like gadgets, and get out the binoculars. For people who are not living and breathing all this information, it might be difficult to discern patterns. They might ask, when can we expect things to improve, or will they stay as they are? And for this reason, I think it is important for the public that we periodically and candidly assess the broad trajectory of recovery of performance, as evidenced by the information you've provided over the last couple of years, and of course, taking into account factors including money and staffing that will come into play in the near future. And because we all appreciate the patient experience that lies below these figures, I'm very much hoping that you will disagree with me here. But for the avoidance of doubt, it is my sense that the recovery of commissioned work in particular will be slow and measured in timescales of years, and that the achievement of targets and ministerial priorities will be limited. And while acknowledging the huge efforts that staff have and continue to make, is this the picture that represents the consensus of NHS professionals? Is it indeed a true and candid picture? Thank you.
Thank you, Robert. Yes, thank you, Chair. Right, so can I disagree with you? Unfortunately, not in the short term. You know, there are substantial performance challenges around A&E, referrals to treatment times, and cancer. And as part of our planning and board development session next week, I will be bringing a set of performance forecasts to how I see the next couple of years playing out in terms of recovery of those key indicators. Some of the variables are complex, but there's also huge opportunities. So, for example, cataract surgery, the getting it right first time recommendation is that for a surgical list with trainees with a relatively low complex patient throughput, that should be 10 cataracts per session. Now, across Wales and across England, typically the average is about 6, but a number of providers are stepping up their throughput to hit those getting it right first time targets. So Neville, our nearest example of that is in Neville Hall. They've just opened an additional cataract theatre to serve the residents of South Paris and Arran Bevan, Cardiff and Vale and CTM. Now they are already up to 10 cataracts per list, and they are saying that by the end of the current financial year, there'll be no patients waiting across that geographic area beyond 2 years. Now, that hasn't taken a lot of investment. That's about using services efficiently and effectively in ensuring throughput. And the GIRFT methodology is a great way for the NHS to recover planned care backlogs. But we can't underestimate the challenge, particularly around the A&E target and the cancer target. We know from all the conversations that we've had this morning that the demand is increasing for services. So those two in particular, I think, are going to be very challenging to deliver. I'm more hopeful on planned care, but as I said, it's we will capture that forward look, which is vital in our 5-year plan, which is coming to board development next week, and then obviously submit it to board for consideration in 2 months' time. Thank you.
Thank you, Steve. We're going to go to Jennifer.
Diolch, Cadeirydd. Jennifer Owen Adams, aelod annibynnol. Steve, thanks very much as ever. A huge amount of work going into this report, and incredibly helpful. I note some of the positive things that are in this report, so I could really tell that from your presentation, so absolutely acknowledge that and really note that. I just wanted to focus specifically on the ministerial priorities, and what you said in your update and what's in the report about where we are against those priorities. And I suppose really my question is, what are the implications for this? Are there any implications for us? Should we not deliver on those priorities?
Yeah, thank you. So we should deliver on them because they're set out as good to achieve, and they're clinically evidenced in terms of the way the targets have been defined. And certainly the ministerial priorities that have been set in Wales, they are all about improving recovery of the waiting list position. All of those are around access standards almost exclusively. So the consequences of not delivering them, obviously patients wait longer. We just immediately increase the backlog of patients that we need to treat in the new financial year and the next period. So whilst any consequences, will get picked up through our routine monitoring with Welsh Government. That's either through our end of year JET meetings or through our monthly IQPD meetings. There are no financial sanctions as there used to be in some of the English setups for failure to deliver targets. So it's really down to what we want for our patients and the pace that we can deliver. That's more important.
Okay, so we do have Ronnie that wants to come in, but I'm going to go initially to Kate and then to Hayley, who may want to respond to some of the questions and observations that have been articulated so far. So Kate, please.
Yeah, thank you. So it is sobering, isn't it? But just, it's probably an obvious statement, Carl and everybody, but just to say that, there's a huge amount of work going on to try and improve efficiencies, chase the backlogs, catch up, but that won't be enough. What we also have to keep our eye on is a long-term goals and long-term prevention. And we need to make sure, and we are doing that. We have a big focus on prevention and trying to get ahead of the curve and trying to stop people requiring surgery in the first place. So I think it's just really, really important that we remember we've got to focus on that at the same time, and that focus needs to stay. Otherwise, we'll be always chasing. So probably stating the obvious, but I think it's important to note.
Thank you. And Hayley.
Yeah, just a couple of points, really. I think, the ministerial targets point, it's really important that we continue to deliver on that. And in part, you set it out, Steve, the patient impact, etc. But also earlier I said that we have managed to maintain our enhanced monitoring status in the last review that was undertaken. If we start not meeting our performance outcomes, we can expect that to deteriorate further. So, and with that comes other issues for us to deal with as a health board. I think the other issue is that I think there is a change, there is a correlation, there has been additional funding allocated to support health boards, for example, to address long waiters, which is contingent on delivery of those outcomes. And so there may well be an impact to that for organisations if they don't meet that in terms of being able to hold on to that funding for the longer term. And that is a shift in the discussions and the conversations that we're having nationally. And then the final point, and I think going back to Robert's point, it's really important that we're as transparent as we can be about the performance, and I think it's relatively straightforward at the moment as a provider, but we are at that stage where we're just drawing together our assessments in partnership with the other commission providers to understand what that profile is going to look like. And I think it is a balance between two elements, really, being clear about what we think we're going to get to in terms of the impact on these targets and particularly impact on patients and setting that out. But also for our staff, it's important that we also celebrate in these meetings the progress that is being made. So it may not be turning quite the curve exactly to where we want it to look like from an outcome target perspective in our IPR, but it actually is making a positive difference, and it is helping the workforce to remain positive and motivated. So those were my additional points, Carl, and you know, I am aware that how we balance that information coming through for the March meeting will be really important. Thanks.
Thank you. Ronnie, would you like to come in, please?
Thank you, Chair. Conscious of the points, the important points that Hayley has just made. Steve, I'm going to take you back to what you said about Robert Jones and Agnes Hunt in terms of orthopedics, and for Hal Dow in terms of colorectal patients, rheumatology and neurology, and indeed Neville Hall in relation to cataracts. So my question is, against the, as it were, extreme long waiters in England, is there any potential for us to further repatriate some of our patients? Thank you.
Thank you, Ronnie. Absolutely. So yes, there is. It's all subject to, though, the sustainability of our services in Paris, and also you know, some key recruitment. So we know that our day case theatres are underutilised, and we could switch that capacity on overnight, but if we had the right staff in. I do believe patients will travel around the system for faster care, as long as the you know, the offer is reasonable, and for those that can't travel, you know, transport is provided in accordance with the policy. So I still think there's a big opportunity for Paris to repatriate back into its own provider services, but also potentially to move patients around the system. So that's certainly the focus of some of the collaborative work across the health boards, to move patients to where capacity exists to speed up access times. But you know, it is a significant challenge to reduce those long backlogs, and it will take a while longer. So I think that inequity of access times that we report on and discuss, that will stay as a feature for some time to come.
Thank you. I'm just pausing just in case Ronnie wants to come back, but
I'm content. Thank you.
Thank you. And apologies, Ian. Ian's been waiting for a little while to come in with a contribution, but do come in now, Ian. Thanks.
No problem, Chair. Really welcome the good news in terms of endoscopy recruitment, because that obviously a lot of effort there. So I think important to recognise that. I've got a specific around the turnover rate for nurse and midwifery staff, just in terms of there appear to be some data problems from what I'm reading of your report there, Steve. This is so what I'm not sure about is whether the graph represents the HCIW figures, whether they represent our figures, and what the difference is and what the problem is there. My final question really picks up on Kate's point in terms of our focus on the long term, and really relating what you've clearly set out here in terms of the things that are within our control and the things that are outside of our control, Stephen. So thanks for that clarification, but also referring back to Pete's financial report and, you know, considerable challenges financially. So I just wondered whether someone would like to comment on the fact it's change is really difficult, for changing the pressures that we've got to meet all of the targets that haven't reduced, the financial situation we find ourselves, but really our focus should be on the long term and that accelerated sustainable model. I don't underestimate the challenge for us as a board, but also the impact on staff and having to focus on all of that simultaneously, as it were, which is the day job.
Thank you, Ian. I know that Deb wants to come in. So Steve, should we go to Deb first before we please, Deb.
Thanks. In response to your question, Ian, the problem with the data is with HCIW, that's nationally collated and reported data on turnover. So it's not a problem our end, and there's some glitches in the system that they're working their way through. So we continue to keep the caveat on there that there are some problems, and you will know because we've reported it through to Workforce and Culture Committee that we do our own turnover assessment, particularly on hotspot areas like nursing and midwifery, where we do know we have a problem. Hope that helps.
Thank you.
Steve, back to you.
Yeah. Thank you, Chair. Yes, Ian, thanks for the question. And it's a balancing act at the end of the day. And you know, when we put our plan together for this current financial year in our IMTP, we described it as our best offer, and that was trying to balance off the finance that we've got, the resource we've got from a staffing perspective, and also the resources of our commissioners, and trying to manage quality outcomes and risk and good governance and progression. So that will be a feature of our of the next paper, and certainly the next planning around that best offer, because we know we've got those tensions between the different domains, whether it be performance, expectation, health outcomes, but there's only a finite amount of resource available, and it's making that sort of best use of that in that balanced way. We can't have one domain rushing off at a tangent, because that will cause issues in the other domains that we're seeking to manage.
Thank you, Steve. That's really helpful. I mean, it seems that our conversation quite rightly has focused and is moving even more towards, okay, this is where we are, but how do we get to where we want to be or where we need to be? And of course, that's the subject of our next agenda item. So unless there is anyone particularly wanting to come in on this report, so I'll just hesitate for a second or two, and there isn't. So we'll go to the recommendation, which is that we have discussed and noted the content of the integrated performance report, and we take assurance that the Health Board has appropriate systems in place to monitor performance and to respond to relevant issues. Please indicate if you don't support that recommendation. So that is supported unanimously. And so I think really importantly now, the next agenda item, 3.3, looks at, you know, how are we going to plan for the future, and how are we going to take on board the comments that have already been made about how can we be realistic, how can we be determined, how can we be methodical, but also how can we bring hope into this situation, which is very problematic. But yeah, I don't want to tee you up. I don't want to place too many expectations on you, Steve. But back to you.
Thank you, Chair. So yeah, this is agenda item 3.3, and there is a cover paper that we've written as a team, and it does span 19 pages in length, and I think that length captures some of the complexities that we're dealing with. But I'll try and take us through what I think are the most important points out of that paper, and I'll refer to the page numbers as we go through this. So this is our integrated plan development, and we've made a decision previously through board development sessions to do a 5-year plan, as opposed to the traditional 3-year that we would have typically done before. So the paper itself builds upon some of the preliminary work that we've undertaken as an organisation, which we started autumn last year, and the paper builds on the planning guidance that we also need to adhere to as issued by Welsh Government, and we received that on the 18th of December. So page 3 of the report captures some of the decisions that we've already agreed upon, which is, you know, vital in terms of that co-production and ownership of the plan as we develop that as an organisation. On page 4 to 5 captures some of the strategic content that we're working within. So we've done the traditional PESTEL analysis of all those factors that could influence us. We've also noted the increased profile and coverage of the NHS Wales executive, any legislative and policy changes, say for example through a Healthier Wales. So all these are vital documents and information that takes our performance and organisation in certain directions. But we also draw out the particular finance and performance challenges of both us, the Health Board, and the wider NHS, which is a key factor in our decision making. Page 6 captures the new revised NHS Wales oversight framework, and as Hayley mentioned, we are in an enhanced level of oversight. So we're in enhanced monitoring, which is now level 3 in the new score structure. It was level 2 previously. It doesn't mean that we've deteriorated, it's just there's a new scoring structure, and so that we are in level 3. So part of our plan will be to at what stage we exit that mechanism, because clearly we want to be back in routine monitoring. Page 7 records that given the current challenges and building on some of the conversation that we had earlier with Robert, there will be a known period of non-compliance on some of the financial targets and some of the access targets in this next 5-year period, whether that be in the medium term or to the longer term. That will be supported by our analytical work as we move forward, as will other organisations as well, given the challenges. Page 8 captures our current health and care strategy, and again, one of the decisions that we took as a board, that still remains absolutely relevant, both to us, our partners, and our patients. And we will work through the remaining months to ensure that our plan is socialised and integrated. So we'll be working with members of the RP Regional Partnership Board, clusters, Powys County Council to make sure that our plan is integrated and coherent as a plan itself. Page 10 and 12 then set out in detail some of the NHS Wales planning guidance, and there are still a number of requirements that we have to comply to with the Health Board. So this is not only a plan for the Health Board, it's also a plan as part of our component part of the wider NHS Wales. So we will need to bear that all in mind when we construct our plans, so that we can demonstrate progression not only against the ministerial priorities, which are a feature again in the new planning guidance, but also our active participation in some of the value and sustainability work streams that are occurring across Wales. Those pages also remind us that all NHS organisations have a statutory duty to break even over a 3-year period. And as I say, although the statutory duty is for a 3-year plan, we are going to do a 5-year plan, and we will be submitting the first 3 years of that. Pages 13 to 16 capture some of the evidence and insights that we're relying upon, and building on some of the conversation that Nina and others, David and such, have referred to. The accelerated sustainability model, better together work with Powys County Council, will be key in our progression through the 5-year planning horizon. And we've also built in some of the learning from the business case development work in the North Powys Wellbeing Project, because that's also quite relevant in this next time period. There's an important graphic in there from Welsh Government in terms of what the NHS would look like in plus 10 years, and that captures some of the demographic challenges we will have, the profile of disease burden we will have as the NHS moves forward across those 10 years. Page 17 captures some of the progress on the strategic priorities, but also sets out the technical and numerical component of the planning. So we are required to submit a comprehensive set of planning documents, a narrative document, what's known as a ministerial priorities templates, but also the minimum data sets that compare that will include all of our workforce plans, our finance plans, our activity plans, and our performance outcomes. Page 18 goes on to describe the timetable for the delivery of the plan and the end products that we'll be producing as a result. Now, there are 3 notable dates that we need to adhere to. So the first one will be the 16th of February. So if as an organisation we feel that we will not be able to submit a balanced plan, then Hayley, in an accountable officer statement, will need to write to the NHS Wales and the Welsh Government setting out that fact. 20th of March will be our March board meeting, where we're aiming to get all these plans approved, and the 29th of March is the day when we all have to submit our plans. And I guess, Chair, in concluding, take it sort of back to page 7 and some of the challenges at the bottom of that page that we've referenced. Yeah, we do know there will be periods of non-compliance. We do know our services need to change to become more sustainable, both from a financial and workforce and performance perspective. So I believe our plan will be very much in that best offer space again over the future planning period. And I'll pause there. Thank you.
Thank you very much, Steve. So does anybody want to come in and contribute to the discussion in relation to the planning paper? Hayley, would you like to comment, please?
Yes, please. So thank you, Steve, because this is really complex. The planning requirements are not straightforward, and there are quite a lot of technical aspects to it which we need to manage, and it's a substantial amount of work. Couple of points from me. The first one is we need to have a very clear position to share with internally with our staff, but also with stakeholders and the wider public. And I see this submission of our IMTP being the start of the conversation with Welsh Government, because I think the level of financial challenge that we're facing, balancing patient care, safety, requirements, essential regulatory requirements and the money is a challenge for us, and therefore how we have that dialogue with Welsh Government once we consider the plan in March will be really important. I think there are some further more detailed discussions that we've got planned as a board between now of the next 2 months before we bring it back to board for final approval. But those are the sort of territories of the discussions that we need to have, which is to what extent we can meet the financial statutory requirements, which is to balance within 3 years against maintaining and continuing to deliver on our statutory accountabilities as well. And sometimes those two together are quite challenging for us, because we know we've got some substantial pieces of work we would need to do to set that plan out. And I think the other issue for me is that I think this will also be setting out the start of a need for a public conversation about dealing with these matters. We won't know exactly how, but we'll be setting out the problems and setting out all the areas that we need to consider. So I just wanted to give that, because I think sometimes we can think about what Welsh Government needs in terms of the requirements that they've set, but we have got a really strong narrative. We've had a really strong narrative in Powys since 2017 when we set the long-term strategy. And I think points earlier made in previous conversations, we've got to balance today with a long term, and we've got to balance ill health with improving the health and well-being of our population. So those are the sorts of areas of discussion that we'll have as a board, and we will bring it back to the March for a final decision. But as part of the next stage of this work to implement the plan, we will need to start that process of engagement and conversation with the public and our stakeholders. On your point, Steve, about how we do that and Nina mentioned earlier, with the position of the local authority is an important one. So I thought I'd just bring those points to the fore, Carl. Thanks.
Thank you, Hayley. Kirsty, please.
Thank you, Carl, and thank you to Hayley, actually, who's preempted really what I want to talk about is where's the voice of the public? Where's the voice of the patient, and where's the voice of the public in the planning? And I guess it goes back to the extensive work that was done prior to 2017 in establishing the narrative for Powys. So I'm glad that Hayley has recognised that this process actually is the beginning of going back out and having some really in-depth conversations with our communities about how they want to see our services develop. And that's not to negate the importance of responding to the minister's priorities, but trying to get that balance if there is a difference between what local population are telling us and what the priorities are maybe somewhere else. Can I just say, Steve, I'm really pleased to see in the plan an emphasis on sticking with prevention. It would be so easy, wouldn't it, to jettison that work and investment in that work, but to the points that Kate made earlier, if we do that, we're just going to constantly be in this cycle and spiral of chasing our tails, really. And then also just to keep reminding ourselves of the inequalities that our communities face and trying to make sure that our plan certainly isn't adding to those inequalities, but actually looking to close those health inequalities within the county. So I'm glad to see that referenced as well.
Thank you, Kirsty. Ian.
Thanks, Chair. A couple of things from me, really, which goes back to the previous conversation. I'm really pleased to note that we're trying to maintain our focus on the longer term. Conscious, Chair, of what you say in terms of we need to inject hope and belief into this and recognising the impact and pressures on staff. We welcome, Hayley, your comments in terms of the need to have a conversation with the public. But I remain concerned this isn't a Powys problem, this is an NHS Wales problem, so we're not going to solve it in this meeting. But I just think recognising the fact all of that ambition is laudable, but there's some basic stuff here that we're not managing. That's the reality of the world that we're living in, that we're not even managing to do the easy stuff. So the example of that I would give was wherever you live in Wales would be clotbusters within an hour. You'd be lucky to get an ambulance within an hour because for reasons that are well publicised. So I think we need to think really clearly about those messages, both to the public and to the minister as well, and that we get a balanced plan. Recognise the need to challenge ourselves, but if we're honest and we're not even getting the basics right here, and I'm sure there are plenty of other examples across NHS Wales. So the sooner we have that conversation with the public, I think the better.
Thank you. And to Nina, thank you.
Thank you, Chair. Following on from a lot of the comments that have just been made, appreciating the issues that are, a lot wider than just here in Powys as well. That's all noted and appreciated. And just wanted to kind of reiterate the importance of partnership working, but I won't go into, what I talked about earlier. I won't repeat myself, but I just wanted to say I welcome, the themes that are coming through in the key draft areas of development, etc. Really pleased to see, importance of strengthening prevention in there, and with my new role that I'll be starting as well. I really think I can work and we can do a lot together in that area as well in terms of prevention. I'm quite excited about what we could do actually, so I'm really pleased to see that in there. And I think we need to really be open and honest about we're going to have to shift investment. We're going to have difficult conversations about disinvestment perhaps as well. And I think that's right. I think it's important that we do that, and that's what we're having to do as well in the local authority, and have a real open and honest conversation with the people of Powys, isn't it? And I think that's really important, and that's where we are as well. In the next couple of months, we're starting kind of widespread engagement across the county, and I just kind of put the offer there that to continue working with Health Board colleagues, if it's appropriate at all, to be sharing those kind of community events or attending each other's or whatever. I think it's just important, isn't it, that we continue to work together on that when we're having these conversations with people and with communities, because yeah, we do have to have a different conversation about people, and I think it's important perhaps that we do that wherever possible together. Thank you, Chair.
Thank you, Nina. Just before I come back to you, Steve, just a kind of reflection from me, really. I think it's really, really helpful, and I think it is hopeful that we're sitting here thinking of considering a 5-year plan. It would, the financial pressures are significant, and the requirements placed upon us are very substantial, and it's always tempting in those kind of circumstances to tick the boxes and be very short term in our thinking, but we're not doing that, and I think that is, for me, is a really positive thing, because short term decisions can actually often remove longer term opportunities. And so really pleased that we're absolutely in that space. And just picking up on Nina's point just then, I suppose a question in my mind is, what will make the next 5 years different? And so, Nina quite rightly mentioned, as did Kirsty, emphasis on prevention, early help, the importance of partnership, the importance of moving resource, what sometimes has been called the shift left. But actually, I've worked in Powys for over 15 years, and we were having those conversations 15 years ago. So I suppose what interests me is, what do we learn from the past about what actually prevents progress? And what is it that we can do differently now that will not bring us face to face with the same barriers and obstacles? So just a reflection. Steve, do you have any words of wisdom, or well, I mean, any final comments?
Yeah, thank you, Carl. I was just going to refer back to Ian's comment. I mean, some of the issues are widespread across the NHS in both England and the devolved systems. They're not just an NHS Wales problem, and lots of effort is being made into trying to fix those immediate day job issues, the ones that we all experience in terms of A&E and RTT and so on and so forth. And I think there are still significant gains to be made in Wales and in other areas through the use of clinical networks, partnership work, and as Nina and Hayley have referred to. And I think, but we've got to decide as a health board what we're going to excel at. So community care, mental health, care close to home, and working closely with adult social care, and then be clear on the services that we don't provide. We want that at a level, because we're commissioning it and we're paying for it. We want those other providers to deliver on our behalf. So I definitely feel that we need an absolutely solid plan that's built on partnership, realism, and sustainability, and it does need to be different to those the previous years that you referenced, Carl, because otherwise you won't achieve anything. And so we need that absolute clarity, but the execution and to stay with it is also really important.
Thank you, Steve. Thank you very much. So we don't have anyone else wanting to come in, so we'll move to the recommendation that we've considered the update in relation to our future planning approach, and that we are assured that this planning approach is in place and will pave the way, as it were, for the development of our integrated plan, but also for our 5-year plan. So does everyone, well, please indicate if you don't support the recommendation. So that's supported. Thank you very much. We change gear a little bit and become a little bit more specific and focused, but we're going to concentrate now on our service provision within therapies and health sciences, and over to Claire, who is the Director of Therapies and Health Sciences in the Health Board. So thank you, Claire.
Thank you, Chair. Yeah, I'm Claire Madsen, the Director of Therapies and Health Sciences. I'm also here with my Deputy Director, Lucy Cornish, who will participate in some of the presentation. Apologies, I've got a really croaky voice today, so please bear with me. So next slide, please, Liz. We're bringing this presentation to you today as part of our assurance programme to the board about the work we're doing in the Therapist Directorate, and also to discuss any themes impacting on our strategic approach to workforce. So next slide, please. So I'm just starting by reminding everybody who is in the AHP and health sciences family, because we are quite a broad and ranging group of professions. And there are more than these actually in NHS Wales, but these are the AHP and healthcare science professionals that we employ within Powys. And we also have some additional people we've welcomed into our family, and those include professionals like social workers. Next slide, please. So what we really wanted to do is just talk a little bit about how we've been approaching some of the workforce challenges we've had within our area, and how we've looked at creative approaches to posts that we've been unable to fill, and new developments. So if we think about our healthcare science professions, we've also looked at repatriation and providing care closer to home. So we've actually trained some of our ultrasonographers to be able to do musculoskeletal specialist ultrasonography, and they're now working locally. We really wanted to strengthen our assurance around ultrasound, so we now have employed a governance lead who's actually looking after not only our healthcare scientists, but also our maternity services and our midwives, who also have scanning functions. We've got other extra areas to support our IT structures. Traditionally, we've never been able to support new graduates into radiography in Powys, and we've managed to re-skill mix our team, so we are actually welcoming new graduates into our team, because we really want to grow our own. We want to provide career structures throughout all of our professions. We've got a brand new profession that's joined us in Powys, which is a cardiac physiologist, and they're here to support our cardiac services. And we recently, you may remember, introduced respiratory physiology into Powys, and we've extended those services that we can offer now, including sleep study services, which we can offer locally. We've got other areas as I've listed, and a new area is we've put audiologists out into primary care so that they can actually support our GP practices, and patients in the community can access services to support their hearing really quickly. Within allied health professionals, which are all of the different professions like physiotherapy and OT and the many professions we have there, we're really thinking about how we can support our elder and frail population, and we have some new roles who are working in that area of specialty, and really looking into areas such as people who are falling or people who are struggling to stay at home. We've got a new role that is an occupational therapist who's supporting perinatal services. We've also got physiotherapists who are based in primary care now supporting GPs. We really wanted to look at supporting early discharge for stroke patients, and one of the areas we found that was keeping patients in hospital a little bit longer was access to speech and language therapy. So we have a new therapy assistant posts there to help people get out of hospital much more quickly. We've been working with Health Education Wales and looking how we can support students on placement better. So we have a multi-professional practice education facilitator who is looking at supporting our students. We've got new dietetics roles. We want to make life easier for people with diabetes who have to attend lots of appointments. So we've put a podiatry healthcare support worker into the retinopathy clinic so that you can have a one-stop shop. You go and get your eyes checked and you can have your feet checked at the same time, because we recognise attending lots of appointments is very challenging for many people. We've got consultant roles in therapists now in several areas, and that includes our musculoskeletal department, in neurology and in pain management. And we very soon have a psychology post starting to support people with neurological conditions. Next slide, please. So everybody's thinking that looks amazing, and where did you get all that extra money from? So actually we haven't. What we've been doing is looking at really hard to recruit to posts and thinking, how can we work differently? So the majority of the posts you've just seen have been funded by reskill mixing within existing budgets, just using our budgets more creatively. We have had a couple of amounts of money given to us by Welsh Government and Education Wales to experiment and look at, can we grow our own posts and develop new posts within a health board. We've had some money to support our allied health professionals working more out into the community and facilitating early discharge. And we had money, as you may remember, to support patients with long COVID, which is also known as the Aferiad funding. Next slide, please. I've just given, we rarely talk about psychology in board, and I just thought it would be useful to give you some updates. I've been doing a lot of work in the psychology service because this is one of our hardest professions to recruit to. We constantly struggle finding psychologists nationally, not just in Powys, and so we've been looking at different kinds of psychologists that we can use, how we can grow our own psychologists, and sorry, well, I'll cover off the psychology one first, then we go back. And different ways we can support trainee psychologists when they're in post to try and encourage them to stay in Powys. So we've actually done a lot of work, and I think this is really evident in the fact that we've reduced our reliance on agency staff by 50%, and we hope to increase that over the next 6 to 9 months. And one of the biggest successes is we've managed to convince some of our psychology locums to stay with us and become substantive members of staff. So I think that's a really important area to look at. And as well as looking at different kinds of professionals and how we work, we're also interested in making our services more effective and more efficient. And one of those ways is to integrate our services more and work more as a multidisciplinary team. So we've been combining our psychology and psychological therapist services. We've combined our community therapists, so OTs and physiotherapists are working much more closely together. We've got a combined WACS management service, which is our audiologists and our ear care nurses working closely together. We're putting our therapy services through a single point of access. So if you want to book an appointment for physiotherapy or podiatry or occupational therapy, you go through the same service, the same phone number, making life easier for our patients. We're really looking at our digital offer. How can we be more efficient? How can we offer digital appointments? And how can we support people to offer digital appointments? And I'll talk a little bit more about that in a moment. We're really keen on working in partnership to see what our wider offering can be for patients. So we're working with other hospitals, we're working with Freedom Leisure Centre out in the community. We work closely with the third sector, and we explore all options we can to give patients the best experience that they can in our services. And just a little bit on the side, which is a little bit technical, but we're really keen on making sure we're really efficient, and so we've done some training with our staff so that they really understand demand and capacity modelling, really looking at making sure our staff have the right skills and they have the right training to achieve that. We use something called Annex 21, which allows us to bring people in at a lower grade, train them and then promote them to a higher grade, so we support them through their development. and we're really looking to give our staff the widest skills that we can. Next slide, please. We're really keen on developing our digital opportunities. So we have our Chief Clinical Information Officer. We've also developed digital facilitation roles, which I'll talk a little bit more about. We're looking at service pathway designs and really looking at our efficiency and making transition through any services as clean and clear as possible. Claire mentioned earlier about our Civica platform, and we've really embraced that in therapies, and we're getting some good results from our patients. And we're making everything as automated as possible. So one of our services now, when you book your appointments, you automatically send all the information that you need, and towards the end of your appointment you will automatically be sent a feedback form to let us know how your experience was with our service. And lastly, we're looking at hosting an online training platform, because we recognise people in the community have jobs, and certain timings of our appointments might not be convenient for them. So if there's a component of education in their treatment, they will be able to access those training opportunities at any time, night or day, on our training platform. And also if they want to have the opportunity to have a look at it once or twice or 3 times, just to make sure they understand it's openly available to them when they need it. Next slide, please. So I talked a little bit about digital facilitators, and I pick up on the point that Kirsty made earlier about equalities. We really want to encourage everybody to be able to access digital services equally, but we recognise not everyone has the same confidence, knowledge and skill, or even access. So we've been working with Powys Library Service and Accessibility Powys to really help people who struggle. And this means that we have facilitators who will actually go out to people's houses and teach them how to use technology if they're struggling. The library service is able to lend people either laptops or any kind of digital facility that they might want to use, including accessible items, as well as giving them data that they can have for free to be able to access our services. And there is a system where we can apply for funding for people to actually have their own laptop at home. So we really hope that we can support everybody to have equal access to digital services. Next slide, please. And speaking digitally as well, we want to support our staff as well as possible to access digital opportunities. So we've been working with the University of South Wales, and we've been looking at how we can use simulation systems to train our staff. So we've done some recent work with the University of South Wales with one of our services, the Powys Living Well service, which has looked at mapping our entire service from front to back and seeing where we're inefficient and where we need more training, and what we can do to support our staff. And staff have really enjoyed these opportunities, and the premise that the university used, which I think is really excellent, is any systems or processes that you develop become free source for anybody else in Wales, so anybody can share any learning or information that we develop. Next slide, please. Okay, so I'm just handing over to Lucy, who will just round up at the last few slides. Thank you.
Thanks, Claire, and good afternoon. So in terms of additional pieces of work that we've been doing, there's been a significant piece of work around professional governance and accountability. So this came out of national discussions in directors of therapy and health science peer group around the increase in numbers of allied health professionals, healthcare science professionals who are working across a range of different service areas now, and not necessarily traditionally within a service where they report to their own profession, and how we best support these individuals to make sure they're meeting their professional standards and that they can do their job to the best of their ability with the support that they need. So we developed some national guidance, and you can see that there's an infographic just on the screen there that really helps us to group those staff and where they might be working and how we support them operationally and professionally to be able to do their job as well as possible and to be able to support service users optimally. Following that national guidance, we've implemented a local framework within Powys Teaching Health Board for every single one of our professional groups, just really clarifying where they go for their professional support, and also a overarching framework for our allied health professional and healthcare science professionals to support them. We've got professional performance meetings in place, which supports the demand and capacity planning and really picks up on any professional elements where we might need to support to ensure that our allied health professionals and healthcare science professionals are able to deliver. And then in terms of policy review and publication, this has all been supported through development of clinical supervision policy, professional registration policy, a standard operating procedure around how staff are managing the caseload, so all the cases that they are responsible for, and as I referenced, our professional framework documentation as well. So all comes together to really support our teams. Next slide, please. In terms of learning, I just wanted to highlight a piece of work that was done within our community services group, particularly in our therapies professions around caseload management and demand and capacity. So this is really looking at making sure that we are using the available time that our staff have in order to care for the patients that they have open on their caseload, and to ensure that every patient that is under the care of one of our professionals has an active plan and knows what that plan is and when their next appointment is. So as you can see from the graph on the slide, in June 2022, for a variety of reasons, the COVID pandemic being one of those, we had open caseloads of almost 20,000 patients on our therapies caseload. With a really dedicated piece of work that has now come down to October 23 to 6,664, really allowing our staff to have that really clear dialogue with each and every one of their patients around their active plan, and ensuring that every patient knows what their plan is for their care. And that's led to a standing operating procedure for caseload management to really support our staff, and it's been developed alongside really enhancing clinical supervision, caseload supervision, and that's been included in our most recent policy update as well to ensure that staff are supported in this activity, and it's also supported by our monthly performance meetings. Next slide, please. Just another example of learning and a really positive project that was undertaken by our MSK, our head of physiotherapy, our professional lead, and the MSK, so musculoskeletal team. They had a really high did not attend rate back in June 2022, which was around between 13 to 16%, which we would be higher than we would like. And they entered into a piece of work with the Safe Care Collaborative, which is an NHS Wales initiative with Improvement Cymru. And they have managed through the introduction of two-way text reminders, so really using the digital innovation that's available to us within the Health Board to bring this down to 6% in December of 2023, and that project is ongoing, and we're really looking to share items of those with other services. Thank you, Chair. Noted there's only 5 minutes left. So just in terms of the next couple of slides, they're really around a survey that was undertaken towards the end of 2023 of our staff to really understand what they feel it's like to work within therapies and health science professions within the organisation, and their opportunities available to them, the representation of their role and other aspects of working within the organisation. So we had 121 responses to our survey, which was really positive, covering a total of 18 areas of work or professions. Next slide, please. In terms of results overview, a really good response rate. Approximately 3/4 of the respondees were aware of how to contact the professional leadership and confident to contact them, with some really positive responses around supporting the role, training needs identification and visibility of professions. Next slide, please. In terms of areas for improvement, we have some around awareness of training plans, and some work to do around just identification of career structure and how we support staff with that, and reaching career goals. So we have developed an action plan, and that's now in place to address the areas identified for improvement, and we'll be sharing that with staff in a "you said we did" communication as we work through those actions. Next slide, please. And that concludes our presentation. Thank you very much.
Thank you both. A lot of information, but really encouraging information. Wonderful to see the progress and the improvements and the strengthening of things. The greater cohesion and cooperation, so on. So really encouraging. Thank you. We haven't got a huge amount of time for questions or discussion, but we do have 2 or 3 minutes. So if I could ask colleagues to keep their questions or contributions as succinct as possible, and then we'll go to either Claire and or Lucy for a final response. So in this order, we'll go to Robert, Ronnie, and then Simon, and then back to Claire and Lucy. Robert, please.
I know you've been championing using the physio in primary care for a number of years now. Are we able, or will we be able, to evaluate the benefit of interventions on MSK in primary care, such as improved patient experience, faster response, GP time saved, and long-term reductions in the number of surgical operations needed? Thank you.
I'm going to hand you over to Lucy for that one because that's her specialist area. So I'll give you Lucy for that one.
Yeah. So what we'll do, Claire, is that if we collect the 3 contributions and then we'll take them together. So we'll go to Ronnie, please.
Thank you. Very briefly, much in this presentation is very positive and very good. Particularly interested in the MSK DNA project and the success of that. And I think there are potentially lessons for other services. So is that capable of rollout in other ways? Thank you.
And Simon.
Ronnie's asked my question. What do we learn from this, and where else can we apply it? Because it seems like a very powerful and positive story of change and real benefits coming out the other side of it.
Yeah, I'll come in first on the DNA project. So yeah, we've really, as part of our demand and capacity work, been looking at DNA generally. So we wanted an area to pilot. So we've done that in MSK, and we did that as part of the Safer Care collaborative piece of work as well, All Wales. So it is being shared as an All Wales piece of work. But we are now thinking where we roll it out within Powys. So we're just about to take it into psychology next, and we're going to see if we can keep replicating it in a rolling programme now of introducing the work that we're doing. So yeah, very much it's all about that was a test and learn, and now we need to see where we can share it and where we can trial it again. So it's currently being rolled out in psychology next. I'll hand over to Lucy though for more detail about MSK.
Thank you, Claire. And just to add, in terms of the MSK DNA project, we've also shared that learning through to the digital team, who are looking at the next stages in terms of the two-way text messaging service, just to add that experience and show the potential in using that function. Just to answer the question regarding the evaluation of the first contact practitioners in primary care for MSK, we have recently evaluated the service in the mid cluster that's been delivered, and that was presented to a panel meeting recently as an update. We've got some really good evaluation data around patient reported experience and user experience from a GP perspective as well, which is really very positive, and we're able to share that with you should you wish to see that. There is really good support around and data around reduced demand on GP time, so increasing their time to care and for other primary care clinicians as well. Again, we've got good supporting data for that and really high utilisation of the service. We now have a service across mid, north and south clusters, and we will be doing the same level of evaluation with those. Slightly more difficult to see from the data at the moment will be any reduction in referral rates and reduction in activity in secondary care orthopaedics, and that's very much because of the context of this extremely high demand that we're seeing across the system going into secondary care services. But we have baseline data and we're now looking to track that, and we have started to see a slight reduction in referral activity into secondary care orthopaedics for those GP practices where we do have our FCP clinicians in place, and as I say, we'll continue to monitor that. Thank you.
Thank you both. As I repeat what I said, it was so encouraging and you know, really welcome and appreciated. I had the pleasure of spending a day with Claire out and about with colleagues a few months ago, and indeed come across things in other visits, and certainly experiencing the motivation. You mentioned, Lucy and Claire, you know, the investment that you've made, not, you know, I don't mean finances, but in supporting staff and growing staff and so on, and just experiencing that sense of motivation for the work and services provided. You know, the impact of the single point of access on improving effectiveness and efficiency, so on. So yeah, it was lovely to be out and actually see some of this in the flesh, as it were, and so thank you very much. Much appreciated. We're going to go on now to item 3.5. Just to remind everyone that we took a decision some time ago now to support the application to close the branch surgery in Gilwern, the Belmont branch surgery. So we're not here today to reopen that discussion, but we did say that we would keep an eye, as it were, on the mitigations plan and whether or not that mitigations plan was having the impact that it was due to have. And so that's the reason it's here. I think possibly for the final time today, but I stand to be corrected on that. But Pete, over to you.
Oh, thank you, Carl. And actually, you've covered the main points of the report in the introductions. So, yeah, this has been a regular item to board, reporting on the mitigation plan and to identify any areas of escalation for the board. Just very quickly, the Task and Finish group met on the 9th of January. In reviewing the mitigation plan and any ongoing issues, there were no issues to escalate to board. The plan is that we'll have a further meeting of the Task and Finish group for mid-March, and at that point we'll make a decision whether we continue with the Task and Finish group or whether we move into just a business as usual type arrangements in this area. And then just a reference for the board, the key areas of focus are included on page 3 of the report. So we're monitoring for any patient concerns or complaints, keeping a review on the community transport, reviewing practice registration and sustainability position, and keeping a track on the wider service provision. So no issues to escalate. The plan is that will be a very quick verbal update to the next board, and that will probably, unless there's any issues, be the final time it's referenced.
Thank you, Pete. And Katie, I just wondered from a Llais perspective, you know, acknowledging your declaration of interest, but is there a Llais comment that you'd like to make?
No, not really. Only to thank the team of both Aneurin, Bevan and Powys for the amount of work and effort that's gone into the mitigation plan and monitoring the mitigation plan. I think, as I've said before, that the sort of start of the process almost was the 1st of December. So again, grateful for the continuation of these meetings, certainly for the foreseeable future. So other than that, Chair, no, nothing else to add.
Thank you. Does anyone else want to make a comment or ask a question? No, so the recommendation is that we receive this update on the mitigations plan and we take assurance that progress is being made on the further development and delivery of the plan. Does anyone not support the recommendation? That's adopted, supported, and so we turn attention now to our corporate risk register and over to Helen.
Thanks, Carl. Pleased to present the corporate risk register to the board today. Just a quick reminder, corporate risks are really those that are categorised as hindering the strategic direction of the organisation. They can't be handled, managed and mitigated within a directorate. They require some broader input in terms of control and management support. So the board does receive the corporate risk register at each of our meetings. You'll recall that throughout the year we've been reviewing those, particularly on the back of the financial scenario planning work that we did earlier in the autumn, and now of course we will be realigning them to the next 5-year planning approach that or planning detail, sorry, that will come to the board in March. So you can expect as a board to see a fully revised corporate risk register in March, excuse me, in line with that planning cycle, and also a review of our board risk appetite statement. So the 12 risks are presented today. 2 of them you'll note are the detail has been retained for the in-committee session of the board. That's the risks in relation to cyber security and national power outage. You did as a board ask us last time to reflect on some of that information being put into the public domain, i.e. the risk scores. We've now done that, so that is available fully, and you also asked us to review the risk score in relation to national power outage, which again we've done, and Carl, I would suggest that we just pick that up in more detail in the in-committee session for the reasons stated. So both of those actions have been taken, but the report is here today to hopefully provide assurance to you as a board that it is a true and fair reflection of the risks as we currently are positioned, but of course very much bearing in mind that they are developing and will be fully revised in line with the plan, as I said. So may well invite any colleagues in to answer any questions in relation to specific risks. You'll see in Appendix A that the risks have been updated in terms of the detail, controls and measures that sit underneath them, and those changes are highlighted in red text just for ease of the board's sight. But that's really the introduction, Carl. Very happy to take any questions or comments from anybody. Thank you.
Thank you, Helen. Are there any comments or questions? Does anyone want to come in relation to this agenda item? Simon, please.
I just wanted to query risk 007, and in part the criticality of good partnership working, and I know from other reports the significant amount of work that has been taking place, particularly with colleagues in Powys County Council. I guess my query is that is work that is underway, and are we content that this is in the green, as it were, as it has felt to me previously not to be in that place, and we are working very hard to improve it, and that's really positive. But are we I think the opening risk perhaps is higher, and I'm not quite sure we're yet at the green effective working partnerships across the board yet. So it's really just a sort of query, and I think some of the updates could benefit from some of that narrative around the work that is taking place, which is really important, and that doesn't quite come across in the update either.
Thank you, Simon. Steve is offering to come in, Helen, with a comment. Over to you, Steve.
Yeah, thank you, Simon. I'll take on board what you say. I think, but I do think we have got effective working relationships. What we're not quite getting is all the outcomes that we would want from those relationships. So we're very active in with every provider around us, and with some of the the networks of providers as well.
Okay.
But what we're not seeing is the performance outcomes that we really do want. So it's making that transition to the outcomes.
It feels an arena where we have further to travel.
Undoubtedly,
I think
yeah.
is what,
Yeah.
you know, in terms of those. Are we still in a position where there are poorer outcomes, and you know the work is still to be done to achieve the better outcomes? I guess is some of my challenge here.
So yeah, no, you're right, and yes, there are still work to be done to improve those outcomes. Absolutely.
Okay,
Helen.
Yeah, thanks, Simon. Thanks, Steve, coming in on that. Simon, just to clarify, it's very much still in the amber rating. The green bit relates to the board risk appetite, so a very open approach to risk. Nevertheless, I don't think that takes away from the point that you make and noting Steve's comments as well, but definitely further to travel and reflected in that amber context for that reason.
And Hayley.
Thank you.
Helen's picked up one point just to say there is definitely more work to be done, and I think that you know, when you're describing it in the corporate risk space, I think that I think there's been substantial changes and probably not reflected quite in the detail of the CRR a detailed sort of report. But, you know, I'm feeling that we've got green shoots of really good relationships in place now, particularly with the local authority and a stable leadership team. That, for it as an example, but also some of the work that we've been doing that Steve's been leading with other providers as well. Increasingly working as separate organisations, we all know we need to work together as a system. So the environment in which we're working in, and probably the burning platform of the challenges that we're facing, is pushing us into the partnership space much easier than maybe earlier or last year. So, but it's one to keep an eye on, and certainly lots more to do to get the outcomes from the work.
Thank you.
Thank you. So thank you, Helen. The recommendation is that we receive this version of the Corporate Risk Register, and that we note that there are a couple of reports in terms of the register that we will deal with in the in-committee session that follows this public meeting. Does anyone not support that recommendation? So once again, that recommendation is supported unanimously. We turn now to item 3.7 on our agenda, and the assurance reports in relation to our partnership arrangements, and to Hayley. Thank you, Hayley.
Yeah, thank you. So I wasn't going to summarise this report, just to say that 3.7 covers an update regarding the NHS Wales Shared Services Partnership, which Pete attends on our behalf. So I don't know if anybody's got any queries on that. And then just in terms of the PSB and RPB, I just wanted to highlight really in the Regional Partnership Board space, and obviously Kirsty currently chairs the Regional Partnership Board. You can see the minutes of the last meeting, but I think again, some really good things to highlight, including the work that we've been doing around planning for the next year, winter system resilience, the work around the strategic capital plan, which I know as a board we've already considered separately as well. And also a really important development is to bring Llais around the table of the Regional Partnership Board as observers to support that role as well. So really good progress in the September meeting of the RPB. Normally we would have a report from the Joint Partnership Board coming through for board, but just for noting that we've taken a decision to stand down the Joint Partnership Board arrangements between the local authority and the Health Board, and instead we've got the Joint Executive Team where we're meeting regularly, and we've got plans to bring together the board and the Cabinet before the end of the financial year to discuss the join up between our work and how we bring sustainable Powys, the work of the local authority, and Better Together, the work around accelerated sustainable model for the health board and the wider system together. That's all I wanted to cover, Carl. Thanks.
Thank you, Hayley. I will ask Pete and Kirsty if they have any additional comments in relation to the shared services or RPB. There may not be, but just before I come to that, the arrangements that will replace the JPB, I don't think yet we've seen the terms of reference, have we? I just wondered where we were in relation to the drafting, the development, and the adoption of those, and what we should expect, as it were.
In the joint session that we're having between the board and cabinet, that's when we'll agree that together, Carl. But happy to pick that up in beforehand, so that board members have an opportunity to discuss further before that meeting. Okay,
thank you. Pete, anything else from you?
No, nothing to add. It's straightforward in the report, Carl, so nothing, thank you.
And Kirsty?
Only to say that it looks like there's quite a lag. I want to assure people that the RPB has met since September. It's just that the meeting in December, the minutes of that haven't been ratified since. But just to say, you know, the work that Hayley outlined, you know, is really gathering pace. And in that December meeting, you know, we were able to agree indicative plans for the new financial year, which is a real step change, actually. And I just want to put on record my thanks to the executive team of the RPB who's supplying that information. And I think there's also been a real step change in understanding delivery of the programme from the various work streams that sit below the RPB and the exec. And I think there's real strengthened reporting. And again, that's testament to people like Hayley and Nina, and Joe and others in the executive space, Claire at Pavo, who are, you know, really being able to drive that and give the RPB board, you know, some really the ability to make timely decisions. So I just want to put that on record. My thanks for that.
Thank you, Kirsty. That's really encouraging to hear, because I know that that's been a bit of a struggle for a number of years, hasn't it? So very, very encouraging. Okay, so we're asked to receive and note the updates contained in the report, and please again indicate if you don't support that recommendation. That's supported unanimously, and we're staying with you, Hayley, for the Joint Committees report.
Yeah, thank you. So again, in three parts. First of all, the report of the meeting that was held in November for specialised services. I'll take that report as read, but we did meet yesterday as a committee, and I just wanted to highlight one area really for awareness to the board. There was reference to the integrated commissioning plan in the minutes in the papers you've seen in November, and we had a draft presented yesterday in the meeting as well, which at that point we were unable to approve due to the level of investment decision making that would be required around that compared to the discussions and how that fits with the overall planning assumptions that health boards need to take as part of the IMTP planning. So there will be an additional extraordinary meeting of WISC having to be put in order to deal with that matter and how that sort of links in to health board plans. So I think that's a really important matter that we pick up as a board as part of the sessions in our plans going forward. So I wanted people to be aware of that. So I don't know if anybody's got anything on WISC, but if I cover EASC next, in terms of the Emergency Ambulance Services Committee, again, take the paper as read from the meeting in November. But again, we met yesterday. A really important meeting and a lot of focus earlier about the additional assurances that we want to seek as a board regarding the performance outcomes of ambulance services. But there were two other matters I wanted to draw to your attention. I think, Steve, you mentioned it briefly in the integrated performance report space, and that was around the work to undertake further actions, high impact actions under the integrated commissioning action plans between Health Boards and WAST, and the progress around that. And there has been some good improvements in some areas, but a need to look at variation in relation to that. And also a really important subject, which is really lots of public interest and opinion about the emergency medical retrieval transfer service and the review that's being undertaken, and very close working with Llais on this matter as well. We discussed the outcome of the option appraisal technical work that was undertaken to look at the long list of options for the future of that service that recommends some preferred options. And we agreed and looked at the engagement materials to go out for the final phase 3 engagement period with the public. And in principle, yesterday, we agreed, subject to Llais being comfortable with the engagement materials, to start that public engagement process this week, finishing off at the end of February. I think it's the 29th. And I just wanted to reassure the board that we'll schedule time, informal time, to brief you on the latest position of that work, but also that we will have an opportunity to look at the outcomes from the findings of that phase 3 engagement, and we'll have an opportunity to discuss that before, and for you to give me as the representative member on the Emergency Ambulance Services Committee meeting, a discussion as a board to inform the mandate that I go into that meeting to offer our view regarding the preferred option. So really important piece of work, and really important that we give due consideration to the particular issues that the population of Powys are raising with regard to this development. So wanted people to be aware of that. And then the one final point, Ronnie, at the start of the meeting, you asked me a question and I didn't answer it properly. I needed to check. You asked me about the national commissioning arrangements, the new joint committee, and the definition of the lay member term. So I've done some checking in the margins. So just to confirm, in legislation, the term non-officer member is often used, and that's the same for health boards and the commissioning committee. So because the term independent member is used as a working title in health boards to distinguish between the role of the health boards and the purpose of the joint committee of health boards, which is this new commissioning body, the chairs have recommended the term lay member, and that's to strengthen really the clarification that these members are independent of the health boards, and will be an important voice to the decision-making process of the joint committee. So I hope that's helpful, and apologies I didn't give you a full answer earlier.
Thank you, Hayley. That is very helpful, and I'm grateful to you for coming back to me. Thank you.
Thank you very much. Katie, please come in.
Thank you, Chair. I just thought it might be useful just to update the board with the situation with regards to EMITS and EASC and Llais, if that's okay. Hayley's mentioned that we had sight of the first draft. We made some comments and observations, primarily that we felt that it had been agreed that all 6 options should be costed, and that needed to be included. And then I think particularly from a Powys perspective, it was important, well, apart from North Wales perspective, it was important that communities and individuals understood where the unmet need was, and actually what the potential impact of the different options were. So last night we received the document, which I guess, Hayley, you probably discussed yesterday, and so we're looking to respond to that document by close of play today.
Thank you, Katie. Are there any comments, questions, contributions in relation to this this report? Simon, please.
It's just in the WISC minutes. I noted that at 7, it seemed a bit confused. It was not supporting a principle, but supporting an ambition on the same thing. And I wasn't quite sure what that was getting at. And that was the paediatric surgery update. But also at 13, talked about a projected underspend of nearly just over 9 million. And it just struck me that this was framed as an underspend rather than a concerted effort to meet a deficit or savings target. And given the pressures in the rest of the system, I just wondered what we should make of that kind of figure of underspend being reported by WISC.
Yeah, okay. Just if I take you on the fifth part of there's always a bit of a pattern of underspending, Simon, against the agreed integrated commissioning plan that we have in place with WISC. So, and that's part of the reason why there's that factor together with the level of additional investment. The draft integrated commissioning plan that we saw yesterday would be equivalent of a 6.4% increase in our allocation of funding towards specialised services. So there's further work being undertaken to understand the relationship between those elements before we'll consider and be able to approve that plan for WISC. So that's the first point. The first point then, apologies, I was trying to open the document and I haven't quite got it. Perhaps I could have another look at it and understand what the point is on that one, if that's okay.
Yeah, that's fine.
Thank you.
All right.
Thank you very much. I can't see anyone else wanting to come in, but just before we go to the recommendation, absolutely support Hayley's comments and indeed Katie's contribution earlier. Very conscious of the significance and the great public interest in the future of the EMERTS decision, and as a board, as Hayley intimated earlier, we will certainly be looking at those options, their implications, and in particular, the implications for Powys people, acknowledging, of course, that this will be a decision by a national committee, but we will certainly be focusing on that very keenly. We go to the recommendation that we note the updates contained in this report as regards the joint committees. Does anyone not support that recommendation? Once again, supported unanimously. In terms of these type of reports, we turn finally to the report of the Local Partnership Forum, and we're going to Deb. Thank you, Deb.
Thank you, Chair. What you have here is a brief update on the most recent meeting held on the 18th of January. You'll have a fuller paper next time. There wasn't enough time for this board meeting. You will see the very long list of areas that the meeting covered. It's always a very participative meeting for which I think we will get a lot of value from. The other bit I would just emphasise is that it was agreed at a previous local partnership forum that we would have a development session. So for this meeting we had the first of those development sessions where we looked at career pathways, and we also looked at the non-pay elements of the pay deal. I'm happy to take any questions. Thank you.
Thank you, Deb. Are there any questions, comments? No, so we thank Deb and colleagues for that report, and we're asked to receive the report and indeed the oral update that accompanies the report. Nobody's indicating that they don't support that recommendation, so that once again is supported. And certainly not least, but finally, we turn to the CLICE report. And back to you, Katie.
Thank you very much, Chair. Just going to take it as read, but just pick up a couple of comments within it, really. I think, as I've shared with you in the past, in Powys, we're very much leading the way as to how we should be or could be working at a really hyper-local level. And we're doing that in conjunction with yourselves and the communities of Powys and the local authority and the third sector. So what we're doing, as I've explained before, is that we are rotating an in-depth deep dive in a very local community. So we've just completed Builth Wells, and we have Llanidloes. We have Llanidloes in February, and we're rotating them north, mid, south, so we're making sure we've got a coverage of the 13 localities, which is the sort of infrastructure that everybody is working to in Powys. What we've done slightly differently this time, which I just wanted to share with you, is that with the following the Builth deep dive, what we usually do is to seek a response from the Health Board and the local authority. And this time, and it was a suggestion from a colleague of yours, we got everybody sat around a table and actually discussed the report with those who'd been involved, with key officers from both the Health Board and the local authority to pull together an action plan which will then be published. So again, it's an evolving process, and it will be interesting to get any feedback that any of you might have, both as members but also as individuals. But it certainly seems to be having a really, really positive response, both from the community and those who we feed the information back to. So it's about how we sort of close that loop, really, the so what element of it that we now need to be working through. So it's quite exciting times, and as I say, if anybody has got anything that they'd like to share with us, but again, potentially it helps inform perhaps some of your planning priorities going forward. It's a mechanism for feeding back to communities, and I know with Nina we've agreed that we will join some of the sustainability panels that are taking place across the whole of Powys. So it's about getting back right down to the local. We've been to cattle markets, we've been to swimming lessons, we've been to knitting classes, we've been to groups that we really have not been and worked with before. So the responses that we're getting around listening to what people's experiences of health and social care are really, really positive. Thank you, Chair.
Thank you, Katie, as always. Jen.
Yes, Katie, thank you so much for that report. Sorry, just waiting for yes. Thank you very much, Katie, for that report, as ever. Really, really so helpful. I just wanted to comment positively about the reference you make to getting feedback from young people. So clearly the work that you're doing is not just focusing on getting feedback, etc. from it's the whole demographic, and I think that's really, really great. Are you finding enough opportunities to go out, or is your organisation finding enough opportunities to go out and talk to young people and garner that feedback?
Thank you, Jennifer. It's been really helpful because, as well as working closely with Nina, I've been working very closely with Lynette Lovell as part of the, the evolution of CLICE. Lynette is the Director of Education in Powys. So to each community we're going into, we're actually going into schools. We're meeting the safeguarding and the wellbeing member of staff, but also meeting school councils or groups of young people who want to speak to us. And we're actually asking them how they would like us to communicate with them. There are issues around confidentiality, that they want to be sure that what they say is kept and anonymised, which of course it would be. So again, as I say, it's something that we're working through. About 3 years ago, we did a piece of work with young people in schools through mental health, but we also need to broaden it out, and it's not just young people in schools, it's young people in community groups as well. So yeah, it's a journey, and if you've got any organisations that you think it would be useful to signpost us to, that would be really helpful.
Thank you, will do.
Hayley.
Yeah, thank you, Katie. And, you know, I know how much work goes into this. It's substantial, but also the way in which you're moving to a thematic analysis really helps us to sort of draw the learning across the organisation. So really grateful for the work you're doing on that. I just thought I'd mention that Carl, the chair, and I met with your colleagues in Llais, with the chair and the chief officer, and you know, I think it's really important for us to know how well we're doing in Powys around this work. It was described by the chair as leading the way, and where they're looking for learning for the rest of Llais. So I think it's you know, I'm very grateful, basically, Katie, and I think for me it's how we as a system bring this thematic learning, but also get the, you said we did approach, which is this feedback loop. And I know that through Adrian and other members of the team, we're working really hard to get that feedback loop in place. So thank you.
Thank you. And just a note in the chat bar there, Katie, that Claire Roche, Director of Nursing and Midwifery, is going to be in touch in relation to the young people's engagement and so on. So yeah, very positive stuff, and certainly echo everything that that Hayley has said. Just before we leave this item, I've also picked up, Katie, that Llais has appointed regional ambassadors. So perhaps not for now, but it would be good to pick up a conversation outside the meeting as to what, if any, kind of working relationship we need to begin to develop with the Powys ambassador, which I understand is the vice chair, Grace Quantock. So, so perhaps we could pursue that.
Very happy to, Chair, and I think, you know, with the Community Health Council, we had a chair to chair and chief officer to chief officer meeting, which was very helpful, and maybe, you know, we need to be thinking about. We also had opportunities of board to board meetings. Now, appreciating we haven't got a board anymore in the same way, I just want to make that offer that I'm very happy at any point, appreciating how busy you are at the moment, but at any point you'd like a bit of an update or a presentation or a discussion, I'm very happy to arrange that with you.
Great. Helen, perhaps we could just make sure that that happens. So the, you know, what does the new relationship begin to look like, and also the role of the ambassador. So great. Thank you. So thank you very much, Katie. As always, as I said, really helpful, and I'm not aware of any other business, so presume and assume that there isn't any, and so it just remains for me to thank everybody for their contributions today. Diolch o galon I chi am eich cyfraniadau heddiw i'n cyfarfod, fel bob amser, cyfraniadau effeithiol, defnyddiol, a chyfraniadau sydd yn helpu ni I yrru ymlaen gwaith, ein gwaith ni fel bwrdd a'r cynnydd dyn ni eisiau gweld yn cymryd lle ym Mhawys. Felly, na, wedi gwerthfawrogi ac wedi nodi. So, big appreciation for everyone's attendance and contributions today, which has helped us to take forward our business and to walk further down that path of progress that we're certainly committed to walking down. So thank you. Our next meeting is on the 20th of March, but we do have an in-committee meeting that will convene soon, and therefore I just put to you the motion that enables that in-committee meeting, and that's that representatives of the press and other members of the public shall be excluded from the remainder of this meeting, having regard to the confidential nature of the business to be transacted, publicity on which would be prejudicial to the public interest. So if there is no one indicating that they don't support that, I assume that all support, and that's supported unanimously. So that brings the this meeting to an end. Thank you, and see you next time.